So I think we are live again. Is that correct, Beverly? Are we ready to proceed?
You're all set.
Thank you. Thank you. So our next speaker is Nancy Sheets. Nancy, we can proceed.
Okay, hopefully you can hear me. Senator Abrams, Representative Steinberg, members of Public Health Committee, thank you for allowing me to speak to you tonight. I am testifying against Bill 6452. I'm Nancy Sheets. I'm the CEO for Farmington Valley Visiting Nurse Association. And while I am a strong proponent for palliative and hospice care, I am speaking to you from the perspective of psychiatry and mental health. I've tried to listen all day and I've heard most of the presentations, so I believe I may be one of the first or few who have spoken to you with direct psychiatric experience. And I am a board certified psychiatric APRN, and I've worked in the field for over 38 years. And I would like to call attention at some point in time, if the bill does move forward, if you could consider line 12 and 13, you defined that the people that make judgment call on capacity are psychiatrists, psychologists, or licensed clinical social workers. And having worked for 20 years in 2 of the primary trauma centers in Connecticut, I could assure you that the people making the judgment call and doing the consultations are psychiatric APRNs like myself. I've been asked to perform hundreds of consultations on patients with some comorbidities of mental illness and also with people who do not have prior psychiatric disorders. I've treated thousands over the years who have thought about suicide as they measure this their only option to end their emotional or physical suffering. And while I know that we are not speaking about some of these patients, I do want to say this: suicide, whether at the hands of an individual or with an assist, should always be considered a traumatizing event. Making the determination of capacity is not always a clear-cut decision. Sometimes it can be fairly straightforward to see that people understand the consequences of their decision. That is what capacity means. Making the determination of whether or not emotions are too strong to suggest lack of capacity is also not an easy determination. Depression, anxiety, emotional anguish are always present when faced with end-of-life crises, and it would be almost impossible to suggest otherwise. Making the judgment call regarding when it's okay versus when it is not always clear, nor can we guarantee, regardless of how well defined your terms and process may be, is that it will be fairly implemented or consistently implemented. Suicide, whether self-imposed or assisted, is still suicide. We agree on one thing: no one should suffer needlessly at the end of life. Unfortunately, we've become a culture of prolonging life endlessly and without awareness of quality. Too many of my colleagues will not have conversations about end-of-life choices because they feel as if it's an admission that they somehow have failed their patients. We limit how we teach people, even on the use of palliative care. And at times we get lost in the worry about addiction and dependency, even when a patient is at the very late stage in the life cycle.
Just to let you know, your 3 minutes is up if you'd like to go ahead and wrap up. Thank you so much.
I really do believe that at the end of life, we have to have the right type of care. And I would urge the lawmakers, despite all of the gut-wrenching testimony about people and their private experiences, to realize that it's a boundary that I don't believe you should cross. And you should hold the medical world more accountable at trying to solve our failing at the end of life, as opposed to you making a law that dictates how to do so. Thank you for your time.
Thank you. I see, and we'll recognize Senator Haskell.
Thank you so much, Madam Chair. And Nancy, thank you for testifying and sharing your perspective. I appreciate all the time that you've waited to participate in this hearing. You know, I was reading through your testimony and there were parts of it with which I really agreed. You said that we've become a culture of prolonging life endlessly and without awareness to quality. And I guess to pick up from your very last sentence, you said that we ought to hold the healthcare system accountable when when we can't provide folks with a comfortable final chapter in their life. But what about when it's no fault of the healthcare system? It's just a failure of scientific achievement or advancement. When the medication is failing to provide the comfort, surely, I won't say surely, I'll phrase it as a question. Have you, in the course of your work, come across folks for whom comfort is impossible in those final days or even final hours?
I'll be honest with you. I think one of the things you have to recognize is that, first of all, to believe that we can always end suffering, I think that's an overstatement. Yes, I think that it's really critical to take care of people that pain medications may not work for. I've treated many patients, of course, the lifetime that that a lot of medications don't have the same impact. I could give you a dose of something and somebody sitting next to you is at the same dose, and it may interact differently. I think that where I believe it's critical to hold healthcare providers like myself or all the colleagues that I've worked with over the years is that we really do a failure here in terms of not bringing up these conversations many years before somebody even has a terminal illness. I think that sedation can be used more effectively than it is used now. And I really think that it's a rare situation where somebody wouldn't be properly sedated at the end of life and allowing that to happen. I will share with you, dehydration, death by dehydration is not a painful process. It is not how people die in pain. There's a lot of fallacy around the thought about, well, I'm starving my loved one, I'm not giving them something to drink. At the end of life, the body can't handle functioning and processing fluids, and oftentimes giving them fluids overloads their system and actually puts more burden on them. So there's a great deal to learn that, we unfortunately have spent so much of our time and energy on making life last longer that we have to do as equally good a job at recognizing when somebody says the quality of their life is not good enough, it's time to help them figure out then what do they want to do, what don't they want to do, and maybe have better bills and laws to allow us to even medicate further and in a way to make it comfortable, because the sedation that you've heard about all day literally gives the body the ability to rest completely and allow it to finish the process.
Well, I appreciate your testimony, Nancy. At the very end, it felt as though we were reaching an agreement when you said that the purpose shouldn't always be to prolong life indefinitely, but to provide some sort of options. I guess we don't agree on what all those options should be. Either way, I won't prolong the conversation. I know we have other to testify. Thank you for your patience. Thank you for what you do as a healthcare provider.
Thank you, Senator Haskell. And you were having a little audio trouble there again, just so you know. But I will go on to Representative Foster.
Hi, thank you so much for joining us this evening. I've learned a lot, and it's been a very long and upsetting day, as I'm sure it's been for most people. But our last speaker shared with us a comparison of terminal sedation versus aid in dying, as is proposed under this bill. And I think even more so now after you've spoken to Senator Haskell, I intellectually am having a hard time wrapping my head around what the meaningful difference is from an ethical or quality of care standpoint between those two options. And I'm not sure that I can say that a clear line exists. And it sounds like one of these options has the potential to be significantly less painful for the person experiencing the end of their life, and particularly less upsetting and painful for the loved ones who are watching that deterioration. So I'm hoping as a provider, you can tell me why and where that line exists. I pulled up a paper comparing the clinical practices between terminal sedation and dignity in dying. And it looks like from a duration of predicted life expectancy, there's not a meaningful difference. It's about a week based on places where they have both practices in place and patients who might be choosing similar things. So I ask, is that week meaningful? And then I also see in this peer-reviewed publication that compares the two practices, because I wasn't familiar, with these two options, that the biggest difference between patients who choose one option or the other is that people who choose terminal sedation tend to be most worried about pain as their primary concern, but it's not the only concern that they have. And those who choose a dignity in dying option are making that choice because of concerns with their sense of suffering without improving, and a loss of dignity, as the title of this bill and practice suggests. So I'm just wondering if it's a week, and if the practice is medically assisted in both situations, what is the difference?
Okay, I cannot speak as an expert from the point of view of terminal sedation. We don't practice that in hospice here. I mean, I'll put my hospice hat back on as opposed to my psychiatric hat. When somebody is terminally ill and they are getting closer, in the hospice world, we talk about seeing signs of them transitioning. We know that there are signs that we can recognize that the person is getting closer. We can even gauge based on the person's symptoms and us watching them, how much more time do we see that happening? Is it going to be within the next few days? I have had nurses who have had to be with family members and help them in the medicating process because it's so difficult sometimes for family members to be dosing morphine. And it is a struggle, but while they want their loved one to be comfortable, they don't want to be thinking that they're giving them that final dose. And so oftentimes our nurses are trying to get them to be able to absorb morphine so that they can relax more. But in the case with ALS, if you've lost your ability to swallow, you're gurgling away. And the last thing you want to do is to exacerbate that or make that worse. Nothing is worse than that sound. I've heard it. My nurses have heard it. It's a horrible thing to witness. I think in those cases, I speak to the fact that, and I've gone to my medical team here at our practice about how, maybe at that point we give them an injection that's not lethal, but that helps sedate them so that their body can finish the process. I can't tell you that there's too many medical providers outside of when you're giving them a cocktail with a purpose of ending their respiratory functions quicker than not, within so many minutes or within an hour or so. And you've even heard testimony that sometimes that doesn't work immediately. I can't tell you that there's a clear-cut line outside of when we put animals to sleep of this dose takes this many minutes. I'm talking more about sedating so that somebody is a bit more asleep, so that the process is not at least as visibly struggling, because it's hard to know. You assume it must be struggling for the patient as much as it is for me to watch it. I think there's other ways to help sedate people so that process can go quicker and smoother. And I do know that when you care for people, you do have a little bit more of an indication when the end is near. I don't think anybody should sit in that process for a week. But we don't practice terminal sedation, so I can't really speak to it.
So if it's not the official terminal sedation, if it's, as you were discussing in your practice, helping them be closer to sedated or more asleep in the end,
Right.
And as you said, hastening the process,
Right.
What is the ethical difference between hastening the process?
I guess that's a mistake on my part to say that. Your body your organs are failing. Usually at the end of life, and many times you're going to die because of multi-system organ failure. I mean, unless it's respiratory distress or, it might be a clear cut related to lung cancer. A lot of times your organs are all going into, one thing leads to another, which leads to another. And that's why you pass away. I believe in sedation to the point of allowing your body to relax, because as soon as and oftentimes when we give morphine, this is the response. It allows the person to relax their muscles and not fight what's about to happen. And it's why in many cases when it is peaceful, it's because the person has been sedated to the degree that they're comfortable, and then their body just shuts down and they don't experience anything that visually looks traumatizing or you can assume would be felt as a a painful or traumatizing experience. I hope that clarifies.
I think the line became more blurred for me, but
Yeah.
I appreciate you talking about it. I think it sounds like a lot of the things that we're talking about are about timelines less than it is about practice. And to me, I'm not sure. I'm having a struggle with that because it sounds like what you're talking about offering through palliative care, which I have so much respect and appreciation for that work that you do. I think it's critically important. It sounds like often folks are seeking the exact same thing through Aid in Dying. And I know you said that you phrased it wrong, but it sounds like the goal and outcome is intended to be similar and perceptibly similar for the person and their loved ones making that choice. But I appreciate you sort of talking to me about this and sharing your expertise. And I agree that the psychiatric perspective is really important. So thank you.
Thank you.
Thank you. I will now recognize Representative Pettit.
Thank you, Madam Chair. Thank you, Mrs. Sheets, for your testimony, and thank you for your comment on feeding and dehydration. That's certainly a common misconception among many people, that those dying are more uncomfortable if they're not eating or drinking. Obviously, as you well know, if they get good mouth care, typically they actually feel better when they're a little bit on the dry side. Your comment about assessment of the mental state. So are you saying that you think it always should be done by psychiatrists, psychologists, psychiatric APRN, and sort of specifically those people only?
No, I was just commenting on the fact of standing up for my practice and my profession that you had excluded APRNs. I know that in practice in psychiatry, we often are asked to do those evaluations. And I read the bill and thought that we were left out.
Okay. But do you think in general it should be done by that group of people as opposed to a primary care physician or some other physician?
I do. And in all honesty, yeah, I do. I mean, I'm on call for Trinity Health of New England. I was for Hartford Healthcare and the Institute of Living for years. And medical providers really are in a dilemma because they so want to make their patients live and live longer. And they will try a lot of things to, and so they struggle at the end of life. And I've often been asked, I can't tell you how many times when I'm on call, to do a psychiatric evaluation because somebody is saying, no, they don't want to have the surgery that the physicians want. And they really do respect your opinion. And oftentimes I find it's not because the person lacks capacity, it's because the person doesn't want to do what you want them to do. And you as the medical provider just can't hear that because to you, it's a failure, or to you, clearly everybody wants to live and not everybody does because they recognize what the quality or what kind of life they have. And they should be allowed to have that decision. I'm all for that. But I do think that most of the medical providers, the teams that I have worked with, have always been very receptive to listening. And as somebody said earlier today, I mean, I've sat also in a number of hearings with Judge Killian when he was one of the probate judges for the state. And I've watched him make determinations with severely mentally ill people who really struggle with some significant illness, but he made very clear the determination that people have the right to make bad decisions for themselves. So capacity is, I've learned a great deal from, I think, some significantly skilled masters, both legally and professionally, how to really tease that out. And I'm just reporting before all of you, while your bill is extremely detailed, and I know you've put a lot of thought into it, it's still not an easy thing to always answer or to believe from my perspective that it's going to be implemented uniformly, consistently, and fairly. It's not easy to figure these things out.
And at the risk of putting you on the spot in terms of opposing this conceptually, for you, does this come from deeply held personal or religious moral belief, or does it come more from the professional side in terms of we've mostly heard from physicians talking about the Hippocratic Oath in terms of the oath of, from the nursing side of things, the APRN side of things. Does that come from a place related to your professional responsibilities and what you feel is right for patients?
My clear bias is that it comes from the world of psychiatry and treating people with and that have contemplated, even just contemplated suicide. Look, I know it is a very separate situation, but I mean, for all my 38 years in practice, we are losing the battle with suicide rates. The COVID pandemic seriously has increased rates among young people. Since I've done this for 38 years, I was a consultant and a trainer. I've spoken so many times to communities on depression, anxiety, on suicide rates. And the sad reality for me is that over the course of my profession, I have noted that it's one of the leading causes of death in the elderly population because people have just decided that they can't do it anymore. And I hate to see that. I took care of a patient at the hospital in the last year who is 92 years old, and he was hospitalized because he drank bleach. Because he wanted to end his life. And the sad reality of his situation was now I was going to be forced to commit him for psychiatric care when 6 months earlier, when he had if someone had had the right conversation with him, he wouldn't have been treated for pneumonia. He would have been allowed to be on hospice. He could have had certain treatments that he was taking that were of no benefit to him any longer taken away. And honestly, he most likely would have passed quite comfortably. I just feel that it comes at a bad time right now and maybe it's because of the semantics, but physician-assisted suicide is still suicide for me, and that's my bias.
Well, I thank you for sticking with the process for 11 hours, and thank you for all the work you're doing at a time when demand is incredibly high for mental health and suicide prevention and the like. So thank you very much. Thank you, Madam Chair.
Thank you. And I see a hand from Representative Betts.
Thank you, Madam Chair, and thank you so much for your testimony. It's been very helpful for me in terms of trying to understand what works best for everybody in this situation. But I think what stood out in my mind was, we do not have a perfect answer. We don't have a perfect solution. And I agree with you. You want to try and do something that's uniformly consistent and meets the goal of what people are doing. But unfortunately, not every situation is the same. And I'm wondering, both sides have very compelling sides, okay? But I'm wondering if we're doing a disservice because we're trying to force something that may not be able to be legislated. And I know that sounds strange, but I'm not altogether sure there is a perfect answer, a perfect solution, or that it's really the role of people who are not in that situation of somebody who's terminally ill. Should we even be inserting ourselves into that as if everybody is going to be the same? And I just don't think we are going to be able to get a consistency and a uniformity, as much as I understand what many of the speakers have said today and really agree. Do you think it's possible or wise to write legislation that's going to meet the goal of what many of the people on both sides of the issue have talked about today?
I think that's why I have hung in there this long, because, I am a passion about nursing. I have a passion about the psychiatric and mental health of individuals. That's just been my, that's where I really have served all of my profession and will forever. And it breaks my heart to think that because the medical world has some weaknesses and hasn't done as good a job at the end of life as it has in prolonging the life, that now we've kind of created this situation where our patrons have to come to the legislature to say, please help me. I think that it's a mistake to think that you should be the ones that help them. And I guess that's what I really wanted to speak most to. This is our failing, and I don't think it should be you that tries to solve it, because you're not going to find a uniform way to do so. I mean, I've listened to these people talk about the suffering of their loved ones. I have sat at the bedside watching this. I have held people's hands. I have done a lot of the conversations at all age groups. It's a horrible situation, but I think that the burden belongs in the medical world with those around us to figure it out better. And I think it would be a mistake to think that a law passed is going to solve the problem uniformly enough without creating problems that you just don't want to get into.
I thank you very much. And that's really how I feel as well. It's not that people don't want to help,
Right.
but we may not be the solution. And more importantly, everything's so individualistic. And I really feel like the people involved know their situation better than people outside it in a governmental role, as well intended as we may want it to be. I just don't know that we're really going to be the answer. And I appreciate what you have been saying, and I'll continue to listen to everybody, but it's a very, very hard thing to figure out. Thank you very much. Thank you, Madam Chair.
Thank you. And Senator Summers.
Yes, good evening. Thank you for testifying tonight. I was struck by a few things that you said, one of them being that the patient you talked about who had been treated, who really, if they were not necessarily treated for pneumonia, they probably would have passed peacefully. And would you agree that there's something very different about not treating versus actively participating in someone's death, writing a script so they can take it and kill themselves? And I think many of the physicians that I've talked to struggle with that. And many of them that I've spoken to, I'm actually married to one of them, who take care of older patients, have said to me that some of the things that they've heard today about what physicians do, and they want to prescribe and overprescribe and make people have surgery, is a really gross misrepresentation of what most physicians do. And that when they meet somebody who, or they have a patient who is, older, and many of them have said, we have patients that tell me I'm ready to die. And the response they normally say, or how they respond is, and we will deal with that when it's your time. And, they tend to write from a plethora of ones that I've spoken to in different areas have had said, I prescribe fewer and fewer meds because I know this person, they've been my patient, I've tracked them. So I think it's important. I know we've heard some really compelling, heartbreaking stories tonight, and there is no one that can't be touched by them, and the depth and the sorrow and the heartbreak that they have caused families. I keep thinking that if we had better palliative care, or if that person had a different physician, the outcome of that process of death could have been very different. So I'd like to get your thoughts on the focus of turning this focus into examining our state's palliative care, our accessibility to mental health, and what we could do in a different way to make the process of death, something that would not have the stories that we've heard today. And that rather than actively asking a physician who has taken this oath to preserve life to actively participate in someone's death. I think it's very different, like withdrawing food, not drinking, as you heard Dr. Pettit say, if somebody's not eating or drinking, as long as their mouth is taken care of, they're actually more comfortable. That is very different to me than actually, here you go kill yourself. And I'd like to get your thoughts on that.
I could respond in so many ways, and I know it's late in the evening already. I will never be a fan of giving you the instructions on how to end your life, and I don't think any of us should be. I do think that, for a while, when I couldn't understand why so many people, I watched our census here, our hospice patients would come on and they would die within a week of coming on service, which clearly meant that they opted for hospice way too late to have even any benefit. And so I went on the road. There was a law firm that wanted me to go, elder care law firm that wanted me to go out and speak. And I would be the clinical presenter, and they would talk about end of life and certain legal matters that people could consider. So they wanted me to host a death cafe. They wanted me to have the conversation, teach people how to have dinner parties and how to bring up this conversation. I said, okay, well, I'm not exactly sure that in my area that's going to be well received. So we actually went to the center part of the state and we had a luncheon, and I got all prepared and I was ready to go. And they anticipated maybe 20 to 30 people that would come. We had 95 people show up for this presentation. And the majority of them were there because they were ripe for having the conversation. We talked about MOLST orders and advanced directives. And we talked about how do you sit down with your loved ones and have a conversation about, gosh, when the time comes, these are things I want, these are things I don't want. The majority of the world does not want to die in a medical facility attached to machines. Everyone will tell you that, but the statistics still show that many more people die there than at home. Nobody wants to die in pain. Nobody wants to die, suffering and being fearful. The sad reality is that we're just terrible about having the conversation. I tried bringing it up one holiday with my kids to share with them, oh, I did this presentation. And the minute I brought it up, everybody's like, oh, Mom, there you go again. We're not talking to you about all that stuff. And I'm like, these conversations should happen at multiple stages of your life when you've reached milestones, your kids have graduated, people are getting married. They shouldn't just be left to when you're old and shriveled up, or you all of a sudden have this awful diagnosis and now you're in a crisis. It's a very hard thing to determine what you really want. And at different points in your life, what you want may be different later on. It might be different 6 months from now. Seeing these people die in hospitals by themselves throughout this pandemic has been horrific for me, because it's just, I can't fathom not being with my loved one at the end of life, but so much never happens in terms of conversations ahead of time. And I've always, for all of the years that I have worked in psychiatry, mental health and psychiatry is like the bad child of the medical field. We're kind of low on the totem pole. There's still not enough insurance coverage and funding. After a while, the world in the world of addiction will say, well, we've given you a lot of funding. You haven't had any more success. So why should we keep doing so? I can't say enough about the fact that if anything, that's where time and energy and effort need to be placed, because there's still significant stigma on mental illness as a whole. When I walk in the room and I tell somebody that that's why I'm there to do an assessment, they pretty much want to kick me out the door. And it takes an awful long time to just talk to them or get them to engage in a conversation, so they realize I'm not there to say they're crazy, and that I probably will be the one person that will understand. And I might be able to get others to understand. I think that when you take away a lot of the different things that we do for people in terms of, the 15 or 16 medications that patients take every day, towards the end, when it just doesn't have the ability to give them benefit, they start to actually feel better. For that matter, I'll be honest with you, we've had hospice patients who have lived well beyond the 6 months and still appropriate for hospice, because there is a slow deterioration, but you take away a lot of things that just give a lot of side effects and people actually rally. So I think it's a terrible thing to suggest that we actively participate in ending that life. I think there are ways to make it by far more comfortable at the end with the right decisions.
COVID has made in our state.
Thank you for that.
Representative Ryan, thank you. Thank you. I don't see any other hands, so thank you for your testimony this evening.
Thank you.
Next, we have Deborah Pasek. Deborah, are you with us? I thought I saw her. There you are.
Do you see me?
We don't see you, but we can hear you.
Hold on. Start video. Okay. There we go.
There you go.
Okay, great, great. Good. I was going to say good morning, but I guess it's good evening. Co-chairs Abrams and Steinberg and other members of the Public Health Committee, thank you so much for allowing me to testify. My name is Deborah Pasek. I have been a physician for 39 years and had been practicing internal medicine and rheumatology in Morristown, New Jersey for 32 years until I retired from that practice in the summer of 2019. I testified before the New Jersey State Senate in support of New Jersey's Aid in Dying for the Terminally Ill Act. It was enacted into law in April, and since April 2019. Since then, I have devoted my professional time to the advocacy, teaching, and practice of medical aid in dying. These past 19 months have solidified my commitment to medical aid in dying. Every patient that I have met, every one, has demonstrated strength, courage, resolve, and gratitude. The end of our visits are filled with emotion, and they leave me with a sense of awe and deep humility. Letters from their surviving loved ones describing the events surrounding the planned deaths consistently describe a feeling of peace, elation, families are brought together, and life is celebrated. I feel honored to have known all of them, and I feel I have fulfilled my oath as a physician to the highest degree, as I have performed the ultimate act of compassion. I have evaluated a total of 43 patients for medical aid in dying. 27 received prescriptions for aid in dying medications, and 14 have gone through with their planned deaths. What I found remarkable about all of these terminally ill people, with no exceptions, was that they were all extremely clear in their requests. Their decisions were made after weeks of discussion and introspection. There was absolutely no evidence of coercion, and all had clear-cut terminal illnesses confirmed by their treating physicians, in addition to the formal process performed by me and the second consulting physician. In addition, there were no barriers in taking the prescribed medications, as currently we are prescribing compounded powders that are easily mixed with liquid to ingest, unlike in the past when a patient had to open and empty 100 capsules before mixing it. All in all, the process has gone very smoothly and peacefully in all of these planned deaths. Yes, there are those who leave their deaths to the decisions of their doctors, family, or their faith. There are those who fight until the end, but all too many wish for a swifter, kinder, and gentler death than what they are experiencing. I believe that those who wish to take autonomous control of their imminent deaths, to have the choice of how and when they will die, they should have the right to do so. I also believe that those physicians who are inclined to support this life and death affirming process should be able to offer the compassionate gift to a terminal patient who requests it. So please pass this bill for anyone in Connecticut with a terminal disease who wishes to decide how and when they die. Time is running out for them. Terminally ill Connecticut residents should not be forced to move to other states like New Jersey that have authorized this compassionate end-of-life care option. Thank you so much for your time and attention. I would be very happy to answer any questions now or in the future.
Thank you, Dr. Pasek, and thank you for being here and sharing your testimony with us. I see Representative D'Amico.
Thank you, Madam Chair. Thank you for testifying, Doctor, at the end of a long day. Maybe we're not at the end, but I guess we're going to find out. So I'm just curious. You talked about the actual mechanics, or you headed in that direction anyhow. So you know, I'm just curious to know from your experience, is there pain involved in the administration of this of the life-ending medication? Could you just talk about that a little bit for us, because you know,
Sure.
I think this would be illuminative to many of us.
Sure. So the medication is dispensed as a powder. which actually has a very long shelf life so that the patient can take it home and just have it there and know it's there. Or they can opt to fill it later, as Dr. Barnard had advises her patients. So this, once the patient has decided to go through with medical aid in dying, then these powdered medications are mixed with a pleasant tasting, sweet, non-carbonated, non-dairy beverage of their choice. Some actually choose a cocktail. An appletini is actually a common choice. And when the medications are ingested, it's a small volume. It's 4 ounces, so it's really less than a cup. There's no trauma. There may be a little bit of burning from one of the medications, only 10% of the time. And we advise the patients to have some sorbet or an ice pop to just, consume after the medication, and the burning goes away right away. The patient is surrounded by their family, and within 5 minutes, the patient just drifts off to sleep peacefully. From that moment on, the patient is unaware of anything that is happening. They are, for all intents and purposes, sleeping comfortably and peacefully. And that is what the family sees. The family sees the patient sleeping. They may have a little smile on their face. They may be snoring. But basically, the family just watches and reminisces and talks. And every once in a while, they glance over at their loved one, and they're still sleeping. Within an hour, most of the time, sometimes it takes a little longer, eventually it will be noticed that the patient isn't breathing anymore. There's no dramatic gasping, death rattle, crying out, loss of body function, no bowel or bladder incontinence. The patient is sleeping 1 minute and then not breathing, and the heart has stopped the next minute. So it's all just so calm and peaceful. And what patients have said to me when they are finished with the process and they are ready to pick up their prescriptions, I have had this said to me several times, and I quote, they say, "Doctor, thank you so much. You have given me my life back." That's what the patient says. And the reason why they say that, I understand why they say that, because they are no longer worried and terrified and anxious about what might happen to them. They may not use it, but they know they're dying. And then it relieves them of that anxiety and that fear, so that then they can focus on living the remaining time that they choose to have left. They reconnect with families, they get their affairs in order, and there's no more fear and anxiety.
Thank you. I appreciate that, because that is something that I don't think we've talked about very much today. Maybe not at all. I've been in and out. So, but thank you for that explanation. I appreciate it. Thank you, Madam Chair.
Thank you. Next, I'll recognize Representative Carpino.
Thank you, Madam. Doctor, thank you for being with us. The beginning of your testimony ran through pretty quick, and I heard some statistics. I think there were a few. I talk quick too, so it's okay. I think what you indicated initially was that you gave us a number of your patients that started this process, the number I think that you said you approved, and then the number that eventually choose that option. Is that what you set out?
Correct.
Okay. Then could you just help us understand a little bit about that percentage that was evaluated but not approved, and what happened to them? And I don't want to belabor it, but I'm curious to know perhaps why, if you can generically tell us why they were not approved, and if they then chose palliative care, or what I hope you're not going to tell us is then, after, in your professional opinion, you did not think they met the criteria, but then they went doctor shopping and found somebody who did. Do you mind just
Sure.
elaborating a little bit?
Sure. I did not say that they were not approved. I just gave a number that I had evaluated and a number of prescriptions that I had written. The bulk, everyone except one patient of the patients that I evaluated but did not get a prescription didn't get that prescription because they died in the 15-day waiting period. So that was everyone but one. One patient did not qualify because she had brain tumors, and she unfortunately could not express herself. She did not have the mental capacity to understand what she was asking for. She just kept saying, I want to die, I want to die, I want to die. And I can't prompt her, but I would say, well, how can I help you? How can I help you? I want you to help me die. But it did not meet the legal criteria for an informed first verbal request. And so I couldn't comply. I didn't feel that she had the mental capacity.
Thank you for clarifying. Do you have any experience by virtue of your colleagues? Is there a small number of folks that don't qualify that seek this out? Is your experience relatively similar to your colleagues? I'm just trying to understand the number of folks who may have difficulty meeting this criteria that seek out their physician for this assistance. And frankly, I worry about them too, which is why I ask.
Sure. Well, as I said before, the vast majority of patients that come to see me have already thought this through. They have discussed it with their families. They have read about it. They're really extremely educated. They have also requested it of their own personal physicians, and their personal physicians have declined to help them. So then they're searching for somebody who can help them. My office, the way we take these calls is that patients do call, and the first thing that my office asks is, we'd be happy to look into this. Please send us your medical records. We did have, and we're talking in 19 months, we had one patient who called who was clearly mentally impaired, psychiatrically so, and she would not even agree to send us her medical records. So that was a red flag already. So my office staff was, they were really great about this. They felt that she really was very unstable and perhaps suicidal, and they referred her immediately to the suicide hotline. So I do have a firewall a little bit in my office, so that people who call do get screened before they ever get to see me. But practically speaking, in these 19 months, it was just one. Everybody else was a patient that really had thought out the whole process and knew what they wanted. And when they made their request, they were like reading from a script. It was amazing, the clarity of what they would say.
Thank you. It sounds like you have an amazing staff. None of us get very far without a good staff. My last question to you, though, is just based on something that you said. I think you said that they came to you because their individual physician opted not. I would just make sure I understood. Your individual physician would not fill out their qualification. Did I understand that right, or did not want to participate? I just want to make sure I understood you and what you were explaining.
Right. So the problem that we've had in New Jersey, the law is quite young, and there has not been, a full education of all physicians. We have a medical society that is opposed to it. So there's not a lot of support for physicians. So the vast majority of physicians either don't know anything about the law still, or don't feel comfortable participating. Even though they may be supportive, they don't feel comfortable actually going through the process of writing the prescription. So we did do a survey within our hospital system where 60% of the physicians are supportive, which kind of parallels the statewide numbers and the nationwide numbers. But we found out, practically speaking, that even if a physician was supportive, they, at least so far, many of them are not quite ready to be an active part of the process. So that's how the patients found their way to me, and that's how I can kind of explain that I, as a rheumatologist, am now one of the major providers in New Jersey for this service, because there's so few of us that are actually doing it.
Thank you. And thank you for your time. Thank you, Madam Chair.
Thank you. Next, I have Representative Foster.
Hi, thank you so much for speaking to us as an expert who has experience in this today. I've asked this before, but I don't think anyone could really sort of get me an answer. We've been hearing a lot about this idea of there being a meaningful ethical difference between what we've heard coined as terminal sedation versus this aid in dying. And I was wondering if you could sort of expand a little bit on if there is a ethical, what you see as the similarities and difference. And I know Dr. Pettit and a few others have referenced this practice of mouth care, making terminal sedation a relatively painless experience if in the end it's dehydration that is the cause of death, of course, secondary to whatever their terminal condition is. That can make the end of their life really comfortable. What I'm really struggling with, if there is or should be a consideration of an ethical difference in this as we're making this decision as legislators, if this procedure is, coined terminal sedation is permissible, then what is the meaningful difference between that and aid in dying, since both seem to be hastening what is already a terminal condition? If you could just explain to me that a little bit from your medical and professional opinion.
Sure. So I totally agree with you. I think of what you're saying is that it's a very blurry line. It's a spectrum of medical intervention in hastening death. So simply turning off a ventilator is medical intervention in hastening death. Increasing the morphine drip to the point where perhaps respiration is suppressed is medical intervention in hastening a patient's death. Terminal sedation as well is medical intervention in hastening a patient's death. The difference between these three and medical aid in dying is that medical aid in dying is the only one that does not involve direct physician intervention. The physician provides the opportunity to the patient, and the patient makes that decision. So in some ways, medical aid in dying is much more, it's less of a physician intervention, direct physician intervention, than turning off a ventilator or increasing the morphine or terminal sedation, because those are active ways that physicians actively participate in hastening a patient's death. So I don't know if that answers your question, but just speaking about terminal sedation in general versus medical aid in dying, another difference is that terminal sedation is literally terminal sedation. That patient is already about to die. If you were diagnosed with ALS and you were rapidly deteriorating, but you could still speak, you could still swallow, you could still breathe on your own, but you had deteriorated to the point where you qualified for hospice, meaning that then by definition, you had 6 months or less to live. You could choose to avoid the horrors of that disease well before you would be eligible for terminal sedation. You can't just say then, okay, give me terminal sedation now. That's not an option. A patient cannot opt for terminal sedation. Terminal sedation is used for patients in whom all other palliative and pain measures fail. And that is when terminal sedation has a role in a patient that is not opted for medical aid in dying and is just dying right away.
And so there seems to be this hang up in this debate about selecting for pain versus loss of dignity and a sense of not being able to improve. And from what I've read, as I've learned a little bit more about these terms throughout this conversation, that is the meaningful difference between those who select terminal sedation versus aid in dying, is that typically those who are choosing terminal sedation, their primary concern is pain, versus those who are choosing aid in dying. It's a combination of things, which also includes loss of dignity. But what I found when I was doing a literature search was that the difference, the shortening in life expectancy from predicted like prognosis date was only about a week difference between those two choices. So to me, it sounds like the doctor involvement is something that we're struggling with the level of, but you're saying that the doctor's less involved, you think, in aid in dying, and that we're also struggling with this idea of direct or indirect intervention that is amounting to a week, but making the person suffering and their family feel significantly different. Their perception of the end seems different. Would you say that that's an accurate assessment of this?
Yes, yes, absolutely. And, you know, when you're talking, and you know, someone who may be opposed to this might say, well, a week is a, you know, wonderful length of time to live more. But to a person who is suffering, really suffering, whether it's from pain, whether it's from inability to breathe, whether it's from existential suffering, you know, 1 extra minute is long enough. And that person, you know, should be able to determine when enough is enough. And arbitrarily saying that, you know, an extra week, you know, it should be reason not to give this option is just doesn't cut it for me.
Thank you very much.
Thank you.
Thank you, Representative Foster. Next is Representative Pettit.
Thank you. Can you hear me all right?
Yes.
Yep. Just a couple nuts and bolts with the new New Jersey law. Can the same physician do the medical affirmation and the psychiatric? 1, 2, is this done in one visit, or does this take several visits? And 3, is this currently covered under insurance policies, or is this all cash since it's so new?
So, yeah, I'm glad you're bringing up mental capacity and a physician's ability to assess that. So, we as physicians assess mental capacity all the time. It's not just about medical aid in dying. I mean, we do it all the time. So, you know, we have a lot of experience in general about assessing a patient's mental capacity, and it's intuitive. It's, you know, I disagree with the prior a person who testified, a psychiatric nurse. It's intuitive. It is obvious when someone is mentally capable. If there's any question in my mind about a patient's ability to make their own healthcare decisions, if there's any doubt, if there's a shred of a doubt, I will refer to a mental health professional. And in my short stint so far, 19 months, I have done so only once. I felt the patient was competent, but I just wanted to make sure, because he had had a suicide attempt many years earlier because of devastating financial situation. And I sent him to a forensic psychiatrist who was, you know, extremely skilled in evaluating a person's capacity. And he, you know, she agreed with me that he was, you know, perfectly capable of making this decision. So I feel that I and most physicians, if not all physicians, have, as part of their training, just an intuitive sense in a patient's mental capacity. And I'm really sorry because I forgot your 2 other questions. So if you can, there were two.
Yeah, can you do the medical eval to say it's 6 months or less, and the psychiatric? And it is typically is 1 visit consultation, and do insurances pay, or do people have to pay cash for it because it's so new?
So as the prescriber in New Jersey, I have to evaluate the patient twice, no less than 15 days from the first visit. And each time I assess the same thing. So I do assess the patient's eligibility their mental capacity, and their ability to self-ingest. And both the mental capacity and the ability to self-ingest can change over 15 days for medical reasons, particularly if there's any brain disease, for both situations. So I do make those assessments. As far as, did that answer your question? Okay. As far as insurance goes, so if a patient's on hospice, then a patient on hospice in New Jersey can't see another physician unless they come off of hospice. I personally do all the work pro bono unless some insurance company happens to cover it. It depends on the payer. Some private payers do, Medicare does not. But again, I have the luxury of being able to do that because I am retired and I'm not earning a living, and that is definitely a barrier for some patients that do seek care for physicians who do charge for their services. The medication itself is relatively expensive or very expensive, depending on who you ask. It costs about $700 for the current combination of meds, which is actually much less than what the Seconal was costing at the end, which was over $3,000. So, but still, I do agree that there certainly are barriers, financial barriers for some people. But some private carriers with really good prescription plans do cover it as well in New Jersey.
Thank you so much. Thank you, Madam Chair.
Thank you, Dr. Pasek.
Pasek. Okay.
Thank you so much. I think, you shared a tremendous amount of information with us and knowledge from your, professional experience. And I think that's always really helpful to the committee. So really appreciate you hanging in there today and being with us this evening. But I see no other hands. So I will move to the next person prepared to speak, and that is Diane Lauricella.
Yes, can you hear me?
Yes, we can. Please proceed.
Good evening. I thank all of you, chair people, as well as the committee members, for hanging in there throughout the day. This is a very important and emotionally charged discussion. However, it's also an important legal and medical discussion. My name is Diane Lauricella, and I ask that you support the Medical Aid in Dying Bill 6425 tonight. My family and my mother had a horrible experience with palliative care, happened to be hospice. She had asked to die at home, but she did not ask to be killed at home through a suffering that when I saw Mr. Russell, he was a speaker, I think number 48, the picture of his sister Dee looked just like my mother when she had been starved and denied her vitamins and food. And we were explained how death comes upon a person, but it took over a week of this suffering. I think that this bill I think that this bill with its built-in guardrails is a perfect way to begin to advocate for the patient. Let's remember who this bill is for. It is for the patient, not for the church, not for the clergy. I was born a Catholic. The patient deserves the dignity, and it's not any of your or my choice to prolong their suffering that can happen with the current status, especially of home care, hospice, as well as dying in hospitals or in home hospice. I think the time has come for us to find a way to fix the small parts of the bill. And we've had many, many good suggestions from Carol Boaz, from Mr. Diaz, from several people that have suggested ways to make this a better bill. I think they can be fixed, including the annual report, some accountability, the death certification designation. It's in your hands to make that, wordsmith it, so that people do not have to suffer. I know for a fact that it's palliative sedation for Representative Foster. That is the issue. Palliative sedation that the psychiatric nurse said is what they choose. She said that we don't do terminal sedation. I think this term of palliative sedation, that is where my mother suffered, and others on this bill public hearing have suffered. So lastly, I just wanted to say it's not a slippery slope if we don't try to inject shame and guilt into this process. Mr. Diaz's words, you need to look at again to compare medical aid versus palliative sedation. That is what we're talking about here. The definition of suicide is death caused by injuring oneself with the intent to die. That is not what people that would like this bill to pass intended. Lastly, I just wanted to say, because the night is getting on, I agree with the saying, my life, my death, and my choice. Thank you very much in your deliberations. Thank you for letting me speak.
Thank you. And I do see a hand, Representative Steinberg.
Thank you, Madam Chair. And Diane, thank you for coming to testify today. You know, you've focused a fair bit on the concept of palliative sedation. We've heard from a number of professionals today that is pretty much the modus operandi for people at end stage, and have assured us that they can manage virtually any circumstance of pain via palliative sedation. Yet you describe a different experience. I know it's hard, but would you be willing to share a little bit more about why that was so? Why palliative care was insufficient in your mother's case?
Well, in her case, she was the kind of person that wouldn't take aspirin for a headache. She was one of those stoic Italians. And unfortunately, it was a complicated case. However, she was assured that her death would be peaceful. And she did not want, once she realized how much the caregivers would be relying upon morphine and other drugs, and that she would be denied her beloved, she took care of herself with supplements, good food, healthy food, organic food, up until just a month before she was induced to die quicker. And the issue is, I just don't understand how, and I asked this of the hospice nurses, how can morphine and starving someone be considered a proper way of pulling a proper use of the Hippocratic Oath on behalf of the doctors that sign off with the nurses? And it's complicated, but I believe that there was a misuse of these drugs. These are drugs as well. And I find that once my mother knew her time was coming, she would have rather not taken 2 weeks of starving and feeling like she couldn't speak with us. She would see us. She looked hollow. She looked dead on her bed. I think she would have taken, because she did have a DNR if she was brought to the hospital, but it got out of hand with home hospice and home care. I have a bill that I was able to get. It's in Health Services number 5907 that just talks about having an ombudsman to help with these issues when they come up. But in the case of palliative sedation, it is sometimes used improperly and not what was promised to our family when she first went into hospice.
Thank you, Diane. And I don't see any other hands. So again, thank you for being with us this evening and sharing your experience with us. And I will move on to our next speaker, and that is Kathy Flaherty. Kathy, are you here?
Good evening, Senator Kushner and members of the Public Health Committee. My name is Kathy Flaherty. I live in Newington. I'm here to testify in my personal capacity in opposition to this bill. You have my written testimony, so the only thing I will talk about is, as a person with a disability, with a lot of friends with disabilities, I took time, because I had lots of time while this hearing was going on, to read the bill multiple times. I'm still against it. I think the fact that you, in previous years, have had additional safeguards in the bill that are no longer there. Representative Cheeseman mentioned hours ago the fact that there's no requirement that the witnesses be people who can't possibly have a conflict of interest. There are some good things in the bill, but ultimately I'm in opposition to it. I think the fact that people rely on there are no reports of coercion, I want people to think about why that might be. If the coercion is successful, the person is dead. The people who are most likely to have coerced them into it are their family members. They have no interest in reporting that the coercion happened. And if the coercion is unsuccessful, these folks have been told by the people most close to them that they're a burden, that they'd be better off dead. And it takes a special person who will admit that something like that happened. But people around the world, disabled people around the world in places that have medical aid in dying, that talk about expanding medical aid in dying, have been told that by health providers. None of us want to believe that a healthcare provider who takes a Hippocratic oath will say to someone, you'd be better off dead. But it does happen all the time. And to deny that it's just not fair. I mean, the experiences that the families have related today are heartbreaking. My father died in my house. I was his caregiver the last months of his life. He had hospice at home. It's not easy for anyone to watch a loved one suffer, but I just don't believe the state needs to be affirmatively endorsing physician aid in dying, so I'm against the bill.
Thank you. Kathy, I have to say, Kathy and I have known each other for a good many years. And, I have a great deal of respect for you. We don't always agree on things, but I have incredible respect for you and the service that you give to people here in Connecticut. You've provided service in so many different ways in so many different aspects of your career. So I consider you my friend, and it's always good to see you even under these circumstances. We do have a question for you. I have Representative Dauphiné.
Hi, thank you, Senator, and thank you, Kathy, for your testimony. My questions, since you brought up the special needs individuals, and that was your concern, and we've heard different people speak to that today. And I have an adult daughter that's special needs, so it's near and dear to my heart. And I was recalling when I went door to door as I was campaigning, and a couple of times I went actually to a door that I didn't realize was a group home or may have had someone with special needs there, and their name was on my voter list. And I actually was unable to talk to them because of the greeter at the door said that they really didn't talk. And I thought it was interesting that they were they were non-communicable, if you'll say. And I thought it was interesting that they were on my list. And it also concerned me as to how many individuals out there might have been signed up for voting that really didn't have any idea who they were voting for, who would sign them up, and how that all came about. And it made me think about this situation and what you're talking about. And I think your concerns with regard to who would advocate for those individuals and what would their interests be. Is that what you're speaking to? Something similar to that, where individuals may not have that ability to advocate for themselves and somebody may intervene on their behalf?
No, and I actually think that's a completely separate issue. What I would point out is that just because somebody is nonverbal does not mean they are not capable of communication. There are a lot of disabled people in the world who do not speak, but they communicate through other means, and they have the right to communicate, and they should be able to communicate. And the problem is that people don't always listen. Occasionally people like to say I'm a voice for the voiceless. That is the last thing I am. What I will do is urge you to listen to the people who you've been ignoring.
No, and I completely understand what you're saying. Many of them are nonverbal, but understand what you're talking about. But then there are those that are not able to understand what you're speaking about. And there's those that are somewhat verbal, but still don't understand what you're speaking about. So I guess I was specifically talking about that group of individuals who oftentimes have workers in a group home per se, or people that are supposed to be advocating for them. And it just made me wonder about, with regard to the voting, and then it made me wonder on this issue, who would be speaking on their behalf. But that's what I was referring to. But I thank you for speaking for those individuals and for your testimony. Thank you. Thank you, Madam Chair.
Thank you. And I see Representative Carpino.
Thank you again, Madam Chair. Kathy, it's good to see you. Sorry it's so late, but if it makes you feel any better, you're well ahead of many others behind you. So I'll keep it a little shorter than normal because I always enjoy your perspective. You pointed out the difficulty in ever establishing that a family member or a physician or someone with a high degree of influence over somebody with a disability, of proving that they would tell someone that their life doesn't matter and that they would be better off dead. I have a concern, and my question to you is it a legitimate one? I worry about our friends and our family here in Connecticut that have disabilities being subject to unconscious bias, for folks who, through their personal situations and sometimes limited living environments and limited circle of caregivers, subconsciously being led to believe that they would be better off somewhere other than this earth, and that they would be better off dead. Am I off base? Feel free to tell me after 12 hours if I am, but I have a real concern with some of those in the disabled community falling prey to unconscious, perhaps suggestion is a better word, from their caregivers about taking advantage of this bill.
I mean, I think that is why you see, because I am a member of Second Thoughts Connecticut, you see people in the disability community who are testifying in opposition to this bill. You've also heard a whole host of people talking who are also disabled, who are in favor of the bill. People have differences of opinions in terms of what should happen with this. I'm in opposition to it, but all of you are the ones who ultimately have to make the decision. I am glad I am not in your chairs because I think it is a very tough call to make. And I appreciate the thoughtfulness with which all of you have been, paying attention to everybody who's spoken today.
And I appreciate your literally answer of not answering, but I will respect that. Thank you very much.
Senator Kushner, you're muted.
Sorry about that. I was saying that was very well said. I really always appreciate hearing from you. You have a unique and strong point of view that is always good to have in our conversation. So it's great to see you here tonight. And I look forward to having another conversation with you about these matters. Oops, I see another hand went up in the last minute. Representative D'Amico.
Thank you, Madam Chair. Sorry to be last minute. Kathy, it's nice to see you again. Thank you for coming to testify at this late hour. So I know we can, trade, statistics and points of view all night long. I'm looking at some literature that was distributed by Compassion and Choices, and I know you're familiar, Kathy, with Compassion and Choices, and they are saying here that in states where this law has been in effect for several years, they have received no complaints of people with disabilities being coerced. Now again, I guess we could do he said, she said, but I just wanted to introduce that because I think I don't know if we can say with any certainty that this is something that's going to lead to abuse or coercion of members of the disability community. Again, I'm looking at literature that tells me the opposite of what you just told me, basically. So I just wanted to say that and hear your reaction to that.
Sure, I was well aware of that literature, which is why I specifically talked in my testimony that you have to critically think about, okay, there are no reports of coercion, but why might that be? If the coercion is successful, the person is dead. The people who are most likely to have coerced them are
Okay.
their family members. There's just no motivation to report it. And if somehow the person was strong enough to resist that coercion, they'd have to be reporting to some kind of public official that their family members thought they were better off dead. I mean, sometimes there are times where statistics may mean something, but the lack of something doesn't mean it's not actually happening. And that's really all I ask you to consider.
Okay. Fair enough. Fair enough. I just felt compelled to introduce that into the discussion, but thank you. I appreciate your point. Thank you. Thank you, Madam Chair.
Actually, that does lead me to a question because it's not an area that I have spent time researching, and I'm just curious if they're in states where you do have aid in dying, is there a larger percentage of the persons that choose that are disabled? Is that a significant percentage of the folks who are choosing aid in dying?
That is a great question. And actually what I would argue to that is that everybody who chooses aid in dying is somebody who has a significant impairment of one or more life activities. So literally everybody who is choosing it is legally disabled under the law. So I don't, that's the only answer I can give you. People do make different choices, but at the time they'd be making that choice, they would have that significant life impairment, so they legally would be considered disabled.
Thank you. I don't see any other hands. So at this point, I think we can thank you for me.
Thanks. It's great to see all of you.
Next on the list is Kim Hoffman. Is Kim with us?
I'm here. Can you hear me?
Yes, we can. Go ahead, Kim.
Okay, great. Good evening, and thank you everyone who has stayed engaged until this point of the testimony. It has certainly been a long day, for sure. My name is Kim Hoffman. I'm stage 4 ovarian cancer survivor. Almost exactly 2 years ago, I came before this committee and testified in support of the Aid in Dying bill. I come before you again today to again support the bill for aid in dying for terminally ill patients. Just as this Zoom is a different venue than before, I am also a different person. 2 years ago, I spoke to you about going to work every day and my commitment as a social worker to all my students. I have not worked since December 2019 due to my steadily declining health. 2 years ago, I spoke about playing tennis matches and running road races. And at this point, walking a mere half a mile takes every ounce of energy and determination that I have. I spoke of long bouts of chemotherapy, and still, I have not had a break now from treatment in 5 years. My disease has metastasized to the point where I am always in pain or some level of discomfort. I'm always fatigued. The days are long, not just this one. Every day is a long, long day, and the nights just seem endless. I've not given up. I began a trial 2 weeks ago, and with the hope that there may still be a chance to stabilize my disease. But this is, I am near certain, my absolute last hope. The trial drugs do not work. My disease will continue to progress, likely rapidly. The pain will get to a point where it is only manageable with narcotics and a steady dosing of narcotics. And the fatigue will likely increase to the point such that I'll no longer be able to perform even the simplest of daily living skills on my own. It's sad to me that my testimony is so grim, but it is what is true and it is what is real. I do not want sympathy, so don't feel sorry for me. Rather, feel compassion. Imagine how you would feel in my situation, how long you could tolerate the suffering, the daily loss of capacity, before you just want to relax and die peacefully. I want that choice. And you may also want that choice. So again, out of care and respect, I implore you to act with compassion and support this bill 6425. Thank you all for listening, and I would be more than happy to answer any question.
Thank you, Kim, and your words are very moving. And I do see a couple of hands, so I will first call on Representative Claritas Demetria.
Thank you, Madam Chair. Thank you so much for your testimony. I can't obviously imagine, Kim, what you're going through. I hope you get to play tennis again, because as a tennis player, I know how much fun could be. So I hope you at least get to do maybe a little bit. I have so much respect for you for the fight you're going through. And clearly you're a fighter through all this. But my question to you is a couple. How long have you been battling this? When did your fight start?
June 2013, the very first day of summer vacation from the school year. So if I make it to June, it will be my 8th year anniversary.
And you come testifying today because you're in support of this bill. Would you have used this for yourself now? If you don't mind me asking, and I understand if it's too personal, but.
It's not too personal, and I appreciate the question. And I really have nothing to hide and everything to help educate and share with people from my own experience, as I've done as a survivor throughout this journey. I have certainly wanted to have the option. I don't believe I would have executed that option at this point yet, because I did start this trial and I'm committed to, doing my best to, stay in the game, and hopefully it works. But if it doesn't work, I'll be kicked out of the trial. There aren't really other trials. I know earlier in the day, early this morning, someone referenced that, they're giving out experimental cancer medications. It's taken me 5 months to get on this trial. And this is one of the very, very few trials that I was eligible, particularly given my late stage of disease. So they're not giving out cancer drugs. They're not giving out experimental drugs. Once you've exhausted what's on the table, if you can't get into a trial, the process just becomes more and more difficult, longer, challenging, painful, debilitating. So to summarize, I wouldn't have done it yet, but I sure do want that option when this pain becomes just absolutely intolerable. And I can't even care for myself, because that's not living and that's not life.
Well, I appreciate you coming here today and telling us your story, and I can completely understand how you would want to have this option for yourself if and when, and I hope never, this time comes. And I think, and I can speak proudly for everybody, that you are an amazing human being and a woman for the fight that you're going through. So I will pray for you, and that you come through the end of this journey of yours, but hopefully this will be something that's there for you if you need it at some point. Thank you again for your testimony, Kim. Bless you.
Thank you.
Thank you, Madam Chair.
Thank you.
Thank you. And Kim, I am going to turn over the chair to Senator Abrams. But before I do that, I do want to say that, I think most of us have had someone in our life that has gone through the kind of struggle that you're going through. For me, it was my father, and now it's my brother. And, so when you talk about your efforts and your hope about this trial, I think we share that hope with you, because we want it to be successful. And so best of luck to you. And I do sincerely hope that this trial is the one that will give you that security living. And for my brother, that happened, and I'm very thankful for that. He is
great.
We didn't think he'd live very long, and he has lived for a number of years and seems to do really well on his new medication. And so, I think there's always that hope out there and hope for you as well. So I do want to turn over the chair now
Thank
to Dr. Doherty Abrams. I think you are here. I saw your hand go
Hi,
up.
Kim.
Hi,
Hi,
Mary.
Kim. It's so good to see you, even under these circumstances. I can't tell you how many times I've thought of you and reflected on the last time you testified.
Thank you.
When I read about this bill, when I talk about this bill, you're often on my mind. So I just think you do have incredible courage to be here and to talk so frankly with us about what you're facing. And of course, you know that I'm hoping that this trial works, and I'm glad that you're still fighting, and I know you, and I know your spirit, and I know you will keep fighting. So I'm going to ask you a really hard question because I feel like you could answer this, and I feel like I can ask you this. We've heard a lot of testimony today about palliative care and about the fact that they can take care of you. You know, they can manage your pain, and they can offer you a what has been described from their point of view, you know, a peaceful end to your life.
Yeah.
And yet, what is it that keeps you from saying, yes, I that is what I want? What makes you want this option instead? If this bill would go
That's a really fair question. I'll do my best to give you a clear answer.
You're always straightforward, Kim. I know you. So.
You know, at this point, to be completely factual, my treatment and care for the past 2+ years has actually been considered palliative. So palliative, and this was an education for me as well, because I used to think of palliative as being the absolute end of life. This is the hospice stage, and palliative is not hospice stage. Palliative is helping someone be more comfortable. So we've known for years now that I'm never going into remission again. And, you know, I haven't been in remission since, I don't know, 6 years. Everything has been trying to treat, to alleviate symptoms and manage disease, to which my disease has progressed so far in so many rare and unusual organs and places on my body. It's actually really rather disgusting for me, but okay, so we go. And so this gets about an individual experience. I've got a bottle of Dilaudid here. I've had a bottle of Dilaudid for, I don't know, over a year. I break the Dilaudid in half. Okay, this is the pain medicine of choice now for me, the narcotic of choice, because I don't tolerate any other narcotics. I take that half of Dilaudid. Within half an hour, I am non-functional. Non-functional. I can't do anything. I can barely get up off the bed. And so when the pain is really bad and I finally give in and say, all right, I need a break. I can't take this anymore. And I take a half of Dilaudid. I know I'm out of the game for 8 to 12 hours. So if it gets to the point where I have to manage on that type of medication all the time, I would be miserable. I would be just so far beyond miserable than I already am, not being able to do all the things that I want to do and love and that bring me joy and life. And to what end? Again, there's no cure. I'm not, once it gets to that point, I'm not going to just remarkably get better. I'm just going to continue to get worse and worse. So, it's interesting to me that people think that And I'd like to actually specifically Representative Summers, and I'm not sure if she's on still, but this morning she gave these assurances as a former hospice worker or hospice employee or something, that she could guarantee that she could make me comfortable and any patient comfortable, and we would die with dignity. Well, being doped out on narcotics is not comfortable for me in any way, shape, or form. And it is not dignified for me. For other people, their choice. They have their own definition of comfort and dignity. And that's why this bill is so unique, because it is up to the individual to choose. And so I want to be able to choose what's comfortable, and I want to choose my own level of dignity. Does that answer the question?
It does, Kim. Thank you. Thank you very much. And
Thanks for
I
asking.
want you to know that you keep fighting for you, and I will keep fighting for you as well. So
Thank you.
There's some
It's a
other
deal.
people who have some questions for you. Senator Wong.
Okay.
Thank you, Madam Chair. I don't have any questions. I just really wanted to extend my appreciation, Kim, for your eloquence and courage in sharing your thoughts with us. Even though we've had a long day, I have to tell you, thank you. And we are cheering for you, and you keep on fighting. So that's all I wanted to say, is to say thank you. And
Thank you
thank
so
you,
much.
Madam Chair.
Thank you,
Thank you,
Senator
Senator.
Wong. Shall I take over now?
Go right ahead, Representative.
Or we can try to do it in
Bye, Kim.
unison if you like. Representative Zupkis, followed by Senator Summers.
Thank you. I almost said Madam Chair. Thank you, Mr. Chair. Thank you, Kim, for coming. And I too am grateful for your courage and you coming before us, and we are rooting for you for sure. I
Thank
just
you.
have a quick question, and I completely understand not wanting to be out on those drugs, and you said taking a half of that Dilaudid knocks you out, and I can totally understand that. And just for my own curiosity, would medical marijuana help your pain at all?
I actually don't tolerate the THC very well either, and the CBDs. It's a little awkward question, but I have gotten approved for medical usage a couple of times. I've tried a couple of times, and it just, my genetic makeup is such that a lot of the narcotic drugs, and a lot of drugs, period, and among which I think really the THC, just don't quite jive with me.
Right.
So
right. Well,
let me tell you, if I could be outside, toking it up and just going and just living life and enjoying that way, maybe it wouldn't be so bad, but I can't and I won't. And that's unfortunate, I guess.
yeah, well,
Probably.
no, thank you. And it's legal, right? So I was just curious because
It's legal for me.
Yeah, yes. So thank you, Kim.
Okay.
Thank you. Senator Summers, followed by Representative Gilchrist.
Yes, good evening, Kim, and thank you for being here. I am still here and listening to everything that you have said intently, and I think you are an amazing role model and very courageous, and I do hope that you will have some success in the trial that you're entering. And I just wanted to ask a couple things. First, my statement earlier about hospice was what I have seen in hospice, that they are able to keep those comfortable and provide a sense of dignity during someone's passing. And clearly those folks have chosen to go with hospice and have palliative care. So in the circumstances that I have seen, there's been a plan or a choice for that patient as to how they would like to proceed, and if they would like to continue with pain meds, that sort of thing. And I just wanted to be clear on what I said before, that they can make you comfortable. And I understand that for you and your decision that might not be what you would like. What I struggle with this bill are, again, the doctor who is preserving life actively participating and taking it. And I can understand how someone wants control over their own body and their own destiny, so to speak, but that's the part I struggle with. And I also struggle with the details of the death certificate and those issues within the bill. So I just wanted to be clear on that. Having worked in healthcare, it's hard for me to see how someone can advocate for both life and death. And I do know that the folks that I have had the privilege of working with will do all they can to end suffering, but not necessarily end life. And so I just wanted to make sure that that you knew that, and that I was more clear, I guess, on what I said as far as hospice, that, you know, those patients have a choice, and I can understand that maybe, you know, in your case, with what your future holds, we hope it doesn't hold it anytime soon, and that these trials are successful, that might not be one of your choices. And that's something that you can have a conversation with the palliative care folks at that appropriate time. So I just wanted you to know what I struggle with within the bill, although I can understand both sides, and I can understand being in a position where you want to control how that time in your life happens. I still struggle with it. So I just wanted to let you know that. And I think that you are amazing to come here again. And I wish you the best. And I really was moved by what you had to say. So I wanted to make sure you knew that.
I appreciate that, but I want to be very clear, because again, you referenced the being able to make essentially me comfortable. Well, I'll put it in my terms because I'm using myself as the example right now. You're saying that you can assure that I can be comfortable, and then you said, but it may not be what I'd like. This isn't necessarily, maybe it's semantics, but I think it's bigger than what I like. It's what I feel, and that is being made comfortable with a myriad of narcotics is not something that I would like, nor is it something, I mean, I'd like it in the immediacy of not having to suffer, but it is not something that would be comfortable. You know, it would not be comfortable for me physically, but it would not be comfortable for me spiritually, psychically, in my heart, in my being, in the person who I am, and the person that everybody I ever encounter knows me to be. So I just want to be very, very clear about that, because when you say it may not be something you'll like, but you can still be comfortable, I feel like that really minimizes it. And that is important, to not minimize the individual's really true and real experience, which is what I'm sharing with you. The other thing that I want to just comment on, and this is a theme that has come up a couple of times also in the day, is this notion that doctors are somehow going to be telling people things that they shouldn't be saying, or telling them things they wouldn't want, or telling them they should die, or something like that. And this is what I'd say to that. You know, I've been in this game now for a long time, and I've had many doctors. And I have been very, very lucky, because for the most part, with few exceptions, I have absolute and complete trust in my medical team, as they do in me. They respect my opinion, they respect my judgment, they respect my choices, I respect their opinion. We have a tremendous working relationship. I truly, with my heart, say, I love my medical team, from the office staff right up through my oncologists. If people are not feeling safe and comfortable with their doctors, and feeling like they're going to somehow misguide them, get a different doctor. Because that should never be the case. No one should be forced to stick with a doctor that they don't trust or they're not comfortable with. It just shouldn't be. And guarantee you, anybody that if anybody's feeling like I don't have a choice or whatever, find me. I'm not that hard to track down. I will help anybody get to a medical team that they feel that they are comfortable with, can trust, and isn't going to like somehow prematurely end their life.
If I can just respond, I think it was semantics. What I meant, and I'm sorry, it's been a long day, as it has been for everyone, as far as the hospice situation, was that in what I have seen, hospice can make patients comfortable if they are comfortable with being medicated. And what I meant was that might not be your choice that makes you comfortable, but I have seen where they can make you comfortable and free of pain. I understand that might not be your choice, but we have seen that and time again. And you explain that being sedated or being medicated does not make you physically or emotionally comfortable. And I can understand that. So
Right.
I think the semantics, I didn't in any way try to minimize what patients are going through in any way, shape, or form. So I want to be clear on that. And I understand we do have to have trust with our doctors. And I agree that no one should not feel trust with their clinician 100%, and that there are clinicians to choose from. I just wanted you to know what I struggle with in this bill as far as clinicians that, that are actively partake in that. That's something that I really struggle with. So,
Gotcha.
Your testimony has given me a lot to think about. And I thank you for sharing that and what you're going through with us in such a direct and personal way. It's really heartfelt and made me think about things in a different way. But I just wanted you to know what I struggle with within the bill. So I appreciate you being here.
Thank you.
Thank you.
Thank you.
Before we go forward, I'd just like to make a comment. We're now more than 12 hours into today's hearing. And we have over 30 people who are still waiting to testify. I'm sure this was not their plan for their Friday night activity. So as we go forward, I would just encourage you to remember that we're here to ask questions and to hear the answers of the people testifying. And maybe we can minimize the amount of debate and commentary as we move forward. Thank you. Representative Gilchrist.
I'll try and do better after this. Thank you, Mr. Chair. Hi, Ms. Hoffman. I just
Good
want
evening.
to, this is my first time serving on the committee too, and I just want to thank you for your honesty. Cancer is not an easy thing to talk about, and you really explained it in kind of what it's like. And when you discussed palliative care for you now, that it's gotten to a point where you're trying to keep the cancer at bay. And I too echo what folks are saying. I hope the trial works and, life keeps going, but I just really do appreciate you being so honest and talking to us straightforward. What also sticks out to me is you mentioning, you said it kind of quick, but you mentioned what you like most to be doing are the things you love, playing tennis. And today we've heard so many things, but what keeps sticking out to me is that the people who want this choice most, love life. They love living. But when they've recognized that that's not going to be the option anymore, they want to have the choice to choose how their living ends. So I just really appreciate you being here. Thank you.
Thank you so much.
Thank you, Representative. Kim, trying to model the correct behavior I just asked for, all I can say is thank you. And you certainly have all of our respect.
Thanks so much.
Best of luck going forward.
All right. Peace.
Next up is number 90, Shannon Sanford, followed by Judy Allen. Looks like you're ready, Shannon. Go ahead.
Good evening, Representative Steinberg, Senator Abrams, and the honorable members of the Public Health Committee. I'm happy to speak to you in support of House Bill 6425, an act concerning aid in dying for terminally ill patients. My name is Shannon Sanford. I'm a registered nurse. I have my master's as an oncology clinical nurse specialist, and I'm an assistant professor of nursing at Gateway Community College, where I teach palliative and hospice care curriculum. Since you have my written testimony, I'd like to use my time to answer your questions and to share with you some exciting news from the written testimony, also in support of House Bill 6425 from Dr. Mary Jane Williams, who's the Senior Policy Advisor for the Connecticut Nursing Association. And I quote from Dr. Williams' testimony: "The American Nursing Association Code of Ethics states that nurses have an ethical obligation in responding to requests for aid in dying. Nurses are obligated to provide humane, comprehensive, and compassionate care that respect the rights of patients but uphold the standards of the profession in the presence of chronic, debilitating illness at the end of life." And this comes from the Code of Ethics of the ANA. "The nurse has a moral obligation to practice ethically and to provide care in a manner that preserves and protects healthcare consumer autonomy, dignity, rights, values, and beliefs, and assists healthcare consumers in self-determination and informed decision-making. In this regard, we believe that House Bill 6425 protects the patient's right to self-determination and both provides appropriate and sufficient mechanisms and safeguards for the patient, the attending physician, and other members of the healthcare team to unequivocally assure all parties' wishes are handled in a legal and ethical manner. House Bill 6425 provides clear steps that a patient must take to request aid in dying and provides that nurses and other healthcare professionals' decision to assist with any aspects in the aid in dying is completely voluntary and without penalty of any kind. The professional role of nursing focuses on meeting the comprehensive needs of patients and their families across the continuum of care. This is particularly vital in the care of patients and families at the end of life to prevent and relieve the cascade of symptoms and suffering that are commonly associated with dying. Therefore, the CNA believes that House Bill 6425 is in alignment with our professional position statement and Code of Ethics to support the professional nurse in advocating for a patient's right to self-determination while providing significant safeguards for all involved in these complex matters. And that statement again comes from Dr. Mary Jane Williams, the Senior Policy Advisor for the Connecticut Nursing Association. She's also a Professor Emeritus at Central Connecticut State University. So I just wanted that to be read into record. I'm also available to answer questions on my own testimony, as well as answer or clarify some of the issues that came up today, such as I know the death certificate has been asked a few times in my own testimony. I provided a link to a document from the CDC that is the Physician's Handbook on Medical Certification of the death certificate. And that actually addresses a lot of the issues that were brought before the committee, where the primary cause on the death certificate should indicate the underlying disease process, which would be your cancer, ALS, or anything of that nature. And that's on part 1 of the death certificate. But part 2 of the death certificate.
Can you hit your 3-minute mark?
Okay. Can I just finish on the part 2 of the death certificate?
Please, go ahead.
On part 2 of the death certificate, for those that are questioning, about the issue of whether or not we could list medical aid in dying, on part 2, you can actually list another contributing condition to death. So for those who want to have a way to track the statistics on that could be noted under section part 2 of the death certificate. So we could actually have our cake and eat it too. We could put the underlying cause on part 1, and part 2, you could actually list medical aid in dying.
Thank you for your testimony. I just want to follow up on just what you were talking about. We were led to believe by testimony earlier today that there was something inherently wrong about listing the underlying cause of death on the certificate. And yet you're saying the CDC explicitly allows that and recommends that this secondary cause could indicate the aid in dying choice? Because this is news to us.
It's my understanding, and I provided you a link to the document in my testimony, that on part 1 is the immediate cause of death. And that's where it's tracked for vital statistics. So that's the most important part. Part 1 is your cancer, your ALS, your most important cause. Part 2 are significant conditions that contribute to the cause of death. So I don't, go ahead.
No, I was just going to say, we're going to have to look at your testimony and look at that link.
Okay. And I'm willing to answer other questions as well in regards to palliative care, if I may. I know earlier somebody asked a question about when does palliative care begin? Palliative care begins at the moment somebody's diagnosed with a serious illness or life-limiting condition. So it doesn't have to wait until, the very end when someone's ill. That's when hospice care starts. So palliative care starts the moment someone's diagnosed with that life-limiting condition. Hospice is more of an insurance term for the last 6 months of a patient's life.
Thank you for that clarification. Senator Abrams has a question.
I do. I just wondered if you could clarify something that you were just talking about. Actually, was what I was going to ask about the palliative care versus hospice care. But it sounds like from what you read that it would be within a nurse's duty, I will say, or obligation to be with a patient, providing hospice care, and be with them when they make this choice, if they make this choice to use aid in dying. Would that be correct?
Yes and no. It is a part of the nurse's responsibility, except if the nurse has a conscious objection to it. If the nurse has a fundamental, it's against the nurse's personal ethics, but the nurse cannot abandon the patient. If that's the case, the nurse has to transfer the care over to somebody who can and is willing to work with the patient.
Thank you for that clarification. So it's similar to the way the bill is written, where a physician could choose, or a facility could choose not to participate in this for whatever their reasons may be, but they would also be having to transfer the care to somebody else. So it would be same as that.
Exactly. But what's very encouraging now is to see that the Connecticut Nursing Association, who essentially is the unified voice for all nurses across the state, is not only saying that they previously, being neutral on this, they're saying they support it. So that's actually a very positive step, toward the legislation, to have them be in support of it. And
yes,
I think
I'm sorry, go ahead.
Good. And I think one of the things, to sort of realize is why we're supporting it. It's an issue of patient autonomy. As Dan Diaz was sort of saying earlier, I know some people are kind of hung up on the issue of, well, the physician, is in control. Should we allow this to happen? It's more of an idea of, I think now more than ever, it's an issue of patient autonomy. Patients want to be in control of their ultimate destination and what's happening to them. And when he explained how he had, his wife, had access to death with dignity, and he saw somebody else suffer from terminal sedation, it's an issue of, patients don't want, to have this paternalistic view now where the doctor decides when everything's going to happen. But instead, they want to be in control of their own bodies and when things occur. So
and they can have both. Because
exactly.
a healthcare provider can choose not to participate if they have a reason to, but there are healthcare providers who will step up.
Exactly.
So, thank you so much. Appreciate it. Thank you, Mr. Chair.
Thank you, Madam Chair. Seeing no other further questions, Shannon, thank you for sharing with us. We will look at your testimony very carefully, and thanks for clarifying those points.
Thank you for your time.
Sure. So next up is Judy Allen, followed by number 92, Colleen Berry.
Hello.
Hello.
Hi. Members of the Public Health Committee, my name is Judy Allen. I'm a resident of West Hartford, and I thank you for the opportunity to speak in favor of House Bill 6425, an act concerning aid in dying for terminally ill patients. This has been a long day, but I want you to know that it's given me an opportunity to get my vaccine and still speak before you. I've also submitted written testimony, so I'm going to be very brief. I support this bill because it creates a pathway for the terminally ill to have control over the manner and time of their deaths. I had a friend who was terminally ill. She was at peace with knowing she was going to die. Her one fear was the manner in which she would die. I will never forget her looking at me and saying, "Please, I don't want to die a hard death." She was frightened that the end of her life would be painful and drawn out. She was fortunate to have had what she would call an easy death, free of pain. But I believe that if she had had the option this bill affords, it would have eased the anxiety she felt. Even if she never used the life-ending medication, just knowing that she had the option would have helped a lot. I think it's natural to think about death as we grow older, and even more so since COVID-19 is with us. It's not death itself I'm afraid of, it's the way I will die. I too would not want to leave this life in protracted pain. I would want the option to make decisions for myself and to die with dignity. Thank you for the obvious time and care that has gone into creation of this bill. I'd be glad to answer any questions.
Thank you, Judy. I have a question which is a little off topic. Did you get your first or second COVID shot?
My first.
Congratulations. We're glad that you've made that progress, and we hope you get your second one right on schedule in 3 weeks. I'm sorry, that was off topic. I'm not modeling good behavior. Does anybody else have a question for Judy? If not, thank you for sticking with us all day into the night and for offering up that testimony. The personal story is very important to us. Thank you again, and have a good night. At least you'll have some night left before you're done. Colleen Berry, number 92, followed by Catherine Farnsworth.
Okay.
We can see you, Colleen. Go ahead.
Tell if you can see me. All right, thank you. Yes, I'm strongly, well, this is testimony in strong opposition to HB 6425, an act concerning aid and dying for terminally ill patients. Sorry, I'm just going to bring up the main points in my notes here. Basically, I'm a veteran. I am currently attending nursing school. And I have to say, part of the reason I've been at your hearing the past few years, and part of the reason I'm going into nursing is the idea that things like this are even being discussed. I'm very concerned. I work with the elderly and suicide prevention in the past. Let me see the main point I wanted to bring. Okay, I've heard often tonight people talking about coercion, and there's nothing's ever happened in Oregon or California or Washington State where there's ever been a problem with coercion. I do want to inform everybody on this. There is no real monitoring. This is just in Oregon. There is no real monitoring of Oregon's suicides. When David Pruitt's failed suicide was made public in 2005, the Department of Health Services publicly stated that they had no authority to investigate individual death with dignity cases. The state law authorizing physician-assisted suicide neither requires or authorizes investigations of DHS. So, like another person said in the a previous person making some statements, you know, one, the person's not going to be here anymore. Two, there's laws like this in Oregon. They've got their whole Department of Health set up to where it would be hard to even have an investigation. So it's absolutely incorrect to say that there hasn't been problems in other states. And then the one last point I wanted to bring up, let me see here. Elder financial exploitation is widespread, expensive, and even deadly in the US, including Connecticut. And then one last point having to do with the elder. I'm very concerned about the elderly. Sorry about that. I'm trying to just bring up the main points instead of reading everything I had. Just a second. Oh, here it is. Yes, sorry, the very last point. Elder abuse is already a big problem. Assisted suicide opens a huge avenue for elder abuse, general coercion from medical personnel to something worse, especially when a senior has money. I'm very concerned, and I definitely would not like to see this passed. Thank you.
Thank you for your testimony. I do not see any questions. So I'll thank you for sticking with us tonight. Next up, we have number 94, Brian Festa, followed by Ann Jackson.
Thank you. Can you hear me?
Yes, we can. Please proceed.
Thank you, Chairman Steinberg and members of the Public Health Committee for hearing me tonight. And I come here tonight on behalf of the Connecticut Freedom Alliance. I want to begin by just saying that I find it a little bit ironic that the committee members, and there's been a lot of discussion from people testifying as well, stating that the government should not be getting involved in these kinds of decisions, that we should leave these decisions to the individuals, to the doctors. And as you well know, my organization is very involved in opposing other legislation that's before you, the religious exemption to mandatory vaccinations, in which the committee seems to have no problem with getting in between the medical decisions of patients and their physicians. So I just want to start off by saying that that's not what I came to talk about tonight, but I do think that that strikes me as rather ironic. The Connecticut Freedom Alliance opposes this legislation, House Bill 6425. And the reason that our organization opposes it is because although it seems to have a very noble objective to aid people who are terminally ill, who are dying, certainly on its face seems to be very noble and seems to be something that would be all about personal and individual choice, and would be something that one would expect we would support. However, in reality, there are some very, very dangerous things about this bill, namely, quite frankly, that it's a license to kill. It's providing the patients, first of all, it provides the patient's healthcare providers with the sole decision to make a determination, the sole authority to make a determination with regard to competency. So for instance, in the definition sections of the bill, it says that competent means in the opinion of a patient's attending physician, consulting physician, psychiatrist, psychologist, or licensed clinical social worker, a patient has the capacity to understand and acknowledge what he or she is doing. The problem with that is it leaves out the individuals who would be in the best position to determine competency, and those are the people that know the patient best, the patient's family members. So once again, not allowing family members to be involved in the medical decision-making process. The other reason we oppose this bill is Section 14 of the bill shows that the bill has a very high potential for abuse. It talks about, again, it seemingly on its face is a very good provision because it provides protection against coercion, against committing what constitutes murder. But the problem with that is the fact that this section needs to be included in the bill is proof positive.
You hit your 3-minute mark.
Okay, if I may just finish the last point. That's proof that the bill has a high potential for abuse. And I know we've talked a lot today about slippery slope, and people don't want to use that word, so I'll use a different word. The camel's nose under the tent, I'll use that term. It opens a Pandora's box, if you will. We've seen in countries that have passed this legislation, such as the Netherlands and Belgium and even Canada, it's been proposed and even passed in some of those countries for children to be allowed to take their own lives. And I know we haven't seen that in the United States yet, because people are going to say Oregon and bring up other examples, but the current trends, the recent trends in the last few years in those countries is to extend this to children. And we are very, very concerned with that. Thank you.
Thank you. Seeing no questions, well, thank you for your testimony. Next up is Ann Jackson, followed by Kristen Keska. Senator Wong, did you have a question? Because it popped up after I said.
No worries, sir. No worries, sir. It's been a long night. And I want to thank Mr. Festa for testifying and his note on consistency. That's all. Thank you, Mr. Chair.
I understand sometimes we're spontaneous, but if you do want to ask a question, make sure you get your hand raised as early as possible. Welcome, Ann.
Thank you. Members of the committee, my name is Ann Jackson, and I'm testifying from Portland, Oregon, in support of House Bill 6425. I've worked in end-of-life care for 33 years. The first 20 as CEO of the Oregon Hospice Association. From 1988 to 2008, I was its representative for all things related to Oregon's Death with Dignity Act, before, during, and after it became law. I'm now an independent and unaffiliated consultant. I testified before you in 2014 that I voted against the Death with Dignity Act. I strongly believe that aid in dying was unnecessary if Oregonians had access to hospice and palliative care. Once the law went into effect, however, I soon recognized how arrogant I had been. There are some very important needs, such as those related to autonomy, that hospice and palliative care cannot meet effectively. I want to finish talking briefly about my life partner, William Carey Duncan III, MD. Bill died very peacefully December 3rd, 2019. He was one of the 188, or the 0.2% that we've heard about this evening already. In October, Bill qualified for his prescription and was receiving excellent hospice care, but he was anxious to get his medication and adamant about using it immediately. I arranged to have a trained volunteer with End of Life Care Choices Oregon to be with us when his medication was delivered. The phone rang as I was telling Bill that Peter, his close friend and the medical director of ELCOR, would be coming at 4 p.m. on Saturday. It was my daughter on the phone, inviting Bill over to watch the Patriots game on Sunday. Well, that's an invitation I can't turn down, he said. His medication was put aside, as it often is. It was enough to have it on hand. On the Friday after Thanksgiving, Bill's daughter, my daughter, and I were able to take Bill from Portland over snow-packed Sandy Am Pass to his cabin in Central Oregon. Blizzards and bomb cyclones had made crossing it earlier impossible. We weren't surprised that he chose to use his medication there. Bill had always lived large and did not want to die, but he died in his own bed at his beloved log cabin in Camp Sherman. We were with him, as was an ELCOR volunteer, when he drank his medication, one of the new DDMP compounds, each component of which is federally approved. He was asleep in seconds and at peace. There were no complications. He died 90 minutes later. His death was a good death, a timely death, and probably days away from a natural death. But he had been so miserable, so very, very, very sick. I miss him terribly, and I'm bereft still, but I'm happy to answer any questions that you have.
Well, let me start by saying we're also very sorry for your loss. He sounded like quite a guy. And, it sounded like you had a wonderful life together, and a classic example of going out on one's own terms, which is, I think, what we're all talking about here. Representative Gilchrist.
Thank you, Mr. Chair. Thank you, Ms. Jackson, for being here all the way from Oregon. One of the benefits of Zoom. Just, since you shared it, and I appreciate you sharing that you used to feel differently, can you explain what your thinking was when you didn't support medical aid in dying?
I really did not think it was necessary. I'd been working in hospice for a number of years by that time, and I believed in hospice. I thought it could do everything, and it certainly can. It's a wonderful support, and Bill's, and I certainly appreciated having it. But there are some needs that hospice really isn't very good at meeting. And those mostly are related to autonomy, making your own choices. Hospice, there are things that hospice can't do. One of the things generally, they can't work with the Death with Dignity Act. That's present because of federal regulations. They provide hospice care, but they generally cannot provide medical aid in dying.
Well, I appreciate you being here tonight, and I'm glad he got to watch that football game.
He did, and that was the end of his talk about using the medications.
Thank you. Thank you, Mr. Chair.
And I bet the Patriots won again. No better way.
I think they did.
Representative McCarty.
Yes, thank you, Mr. Chairman, and thank you for your testimony this evening. Can you tell me, when you look at the Connecticut proposal and juxtapose it with the Oregon proposal, is there a section, because I couldn't find it in the Oregon piece, on counseling the individual prior to making the decision? And if there is there a follow-up to the counseling? And in the Oregon bill, what is the nature of the counselors? We've specified in Connecticut 3 areas, but I'm wondering what Oregon has, if you could answer that. I'm looking for you, but I don't see you. Sorry.
I'm second, as usually, as the person. The Oregon Hospice Association, or excuse me, the Death with Dignity Act does not require counseling unless there is a reason to believe that the patient's ability to make healthcare decisions is compromised in some way by a psychological impairment. Psychologists and psychiatrists are eligible to provide those consultations. Very few people are referred to those consultations, however, because by the time somebody gets to the point of being able to make the get a prescription, they've already been fielded out. The people who would not qualify are no longer in line to get the prescription. It's a long process, and most of the people get there are capable.
Okay, well, thank you for that response. And then on the request, if a patient wants to rescind their original request, and then the second request, do they have to have witnesses present? I see in our proposal that it can just be in any manner, shape, or form that the request is made. And just curious, because it would seem to me that it would be a better situation if there was some proof of that, because we have no way to know if the patient then decided to change their opinion if it was just verbal.
Patients can rescind their request at any time. There is one written request. Both oral requests have to be serious requests. One cannot just say, and oh, by the way, doctor, I would like to have a prescription. They have to be very specific so that the patient and the doctor both know what they're talking about. The written request also has to be very specific.
I'm looking at the reverse of that, excuse me, Anne. Thinking, I'm looking at when and if a patient wants to rescind the request. I understand when they're making the request, but now I'm looking at the second part to it.
Just saying no is adequate. The request, it's not until the written request is filed that anyone has any records of this, or when the prescription is written is the time anything is filed, when it becomes a part of the record.
Right. Well, I was just trying to look for that extra protection if the person said no and it was just verbal, and then there was a dispute, said, oh, I didn't hear that. But if you had it.
But they wouldn't have to take the medication if somebody gave them a prescription either. And you don't have to, that doesn't need to be written. It's just a no.
Okay.
Somebody could do that if they wanted to.
Okay. Thank you very much.
Thank you, Representative. Representative Betts.
Thank you very much, Mr. Chairman. And just following up on Representative McCarty, I'm trying to understand. I realize that the patient can say no. Then they may say yes after that. But just for the sake of making sure there's no miscommunication or misunderstanding, would it not make sense to say if somebody had a change of heart or change of mind, that would be in writing so that there would be no debate or doubt as to whether the person really did change their mind or the reason for their changing mind?
It's a responsibility of the patient's doctor, the attending physician, and of the consulting physician to keep a record of all of the things that go on with the request and the submission of any of the written or oral requests. They all must be documented. So the rescinding would be documented by the doctor, and the doctor is the one who gives the report in Oregon, the doctor is the one who is reporting the deaths of these patients. Every time they write a prescription, they submit this information. So we do have a record, and that's how the state can go back and look and count who it is that's used the law, who it is that didn't use it. The law doesn't take into effect until that prescription, the first request is made, the written request is made, the oral request is made, the 48 hours following the last, the written request before the prescription can be filled. Those are all parts of the doctor's records, and then it's filed with the state. And a death otherwise, the death is not a death with dignity, a death with dignity death.
Okay, thank you very much. Thank you, Mr. Chairman.
Thank you,
It can be
Representative.
complicated.
I'm sorry?
It just can be, there are so many little steps to the pointing to try to determine where anyone is on this. But the law itself does have the list of the requirements of the attending physician.
Well, that's something we're going to have to look at carefully ourselves, because we are, at least the intent of this bill is to closely emulate the Oregon experience. So we'll look at that carefully. I see no further questions. Thank you for your testimony, particularly given your real world experience in Oregon. It gives us a very important perspective. Thank you. Next up is Kristen Keska, followed by 97, David Reynolds.
Mr. Kamasi's book, The Magenta Project, seems to cover my thoughts on aid with dying well. Death with dignity includes both a natural death and a medically aided death. Compassionate death is one's own definition. For those with a strong faith in life, they get to live it and die on God's terms. And HB 6425 allows those still with faith or not the right to avoid their greatest fear, physical pain, and mental suffering. This law allows for the purple. It does not deny anyone their belief on how they wish to pass from this world to the next. Even my own house is magenta. I have a DNR. My husband wants to live forever. We have this desire secured in our living wills. While I will consider dying in aid, he would not. And we trust each other and do not argue over our differences. It's a personal choice. And at the same time, if I had stage 4 cancer and my doctor even hinted on a way that could cure or lengthen my life significantly, I would do it for my young daughters because I'm only 37. But 30 years from now, I may not. My written testimony includes the truth of my mother's graphic passing, includes pictures of my mother before her cancer up to the night before she died. Mr. Sherman Gillums, my mother's story is in the scope of this proposed law. My mother, Karen Selfman, never hid anything from her friends and family, including 2 very important points. 1, she wasn't going to make it past 60. And 2, when she did get sick, we promised we would pull the plug. I swear she would repeat this every year of her life or so for decades, and even more in the last few years of her life. She made this decision when she wasn't vulnerable, as Mr. Gillum suggested. My dad and my 2 sisters knew clearly what my mom wanted, and it was even in her living will. So on Friday, August 2nd, 2019, when my mom went to the hospital thinking she had appendicitis and left learning she had an aggressive 10-inch tumor on her ovaries, I instantly wished we lived in Washington State or the other locations that allowed for my mom to die with her version of dignity. From her diagnosis to her death, it was 8 weeks. Loss of autonomy should be considered pain and suffering. Dr. Kamosi said when they have good palliative care, they won't want this. My mom paid pennies for her quality palliative care. She had all the options available in front of her, and money was no issue. The doctors gave her many options, knowing she was terminal. Representative D'Amico, your point is spot on. My mom suffered with the best palliative home care. but it still did not prevent her from her last 5 minutes of life either. What I saw with my dad and sisters will be forever ingrained in my memory and only reinforces my advocacy for a terminally ill loved one's right to choose their own passing. After a half a day of death rattle, her breath instantly changed to gasping for air. Then we all witnessed her eyes shoot open in what looked like horror as she looked for us around the room. Then the fluid and foam started to come out of her mouth. She was drowning from the inside out. And all we could do was hold her hand, say the Lord's Prayer, tell her it was her time to go and it was okay, and that we would take care of my dad and her grandkids. I attest Kim Callahan and what Dan Diaz said. My mother was sent so much medicine that if we chose to medically aid her in dying, we could have. She was prescribed over 100 pills of oxycodone-type medicine and vials of morphine. By Friday, September 20th, 1 week before her death, hospice told us that she was not allowed to touch her medicine again, that we are now basically her doctors. But to our family, removing life support with doctor's assistance because of a DNR is one thing, but giving your mother too much medication to help her die is against the law. And this is why I want to address Representative Betts directly. My family follows the law, and this is why this law needs to be created. We could not, with good conscience, give my mother too much medicine because by law, that would make us her murderers. And as Dr. Marine, Dr. Gray, Dr. Jacobs attest, they won't support hastening someone's death. Nor did any nurse whisper into our ears how to help her pass. States that allow terminally ill patients to choose their type of passing. To choose their type of passing have a two-part system. A system that is meant to gracefully and peacefully assist in death, which is not the same as overdosing on oxycodone or morphine, which my mother had plenty prescribed. Nothing is too sensitive for me. Like my mom, I am brutally honest. Please ask me questions. I would love to address Representative Zupkin's question to Kim Hoffman with medical marijuana and my mother not being able to get it, or make a few more comments on what hospice care at home was in reality to what I thought it would be before cancer started. Or finally, what happens to that medicine once the patient dies? I have answers to all those if you want to ask. Thank you.
Thank you. I think you underscore the point that where we might all endeavor to be with our loved ones at the end, it's not always a wonderful, enduring experience. It sounds like had quite an effect on you. And I would also have to totally agree. You are very direct and brutally honest, and I will ask you about specifically your experiences with hospice at home.
Okay.
If you would mind elaborating.
Just so you know, I mentioned my husband and my dad, they're both in the background, so you'll hear your questions too.
But that was a question, even if it wasn't phrased in the form of a question like on
Oh, so hospice care.
If you wouldn't mind.
So I always imagine, I know my parents wanted to die at home. I know both of them, my dad doesn't want to, my mom didn't want to die in a hospital. So after her chemo, and she went rapidly downhill, literally she went from chemo to death within like 13 days. The doctor was even saying, you know, some people have a bad reaction to chemo. I mean, more than just the normal bad reaction, like literally her body just shut down after chemo. So the palliative care that she was hoping for a little bit of an extension of her life didn't happen. So anyway, I imagine that hospice care would be more like, you know, like at home workers where they come to your house for many hours of the day helping you. It wasn't that. They came, they said it was instant. Like when my mom made the decision from going from palliative care to hospice care, which I think we now understand the difference, they came that day with all the beds and all the equipment she needed, which was great. But then we realized that the nurses weren't coming every day, or sometimes in the beginning, every other day. It was every 3 days and then every 2 days. And then the day before she died, we saw them back to back. So what ends up happening is they give us all these details, but I'm not a nurse nor a doctor. I love my mom, and I want to make it very clear for pro and con people that I would do this over and over and over again for any of my loved ones if they chose this path to go, which is the natural cause, but my mom didn't want that. So what I expected was to have a lot of nurses around. They weren't there. So my sisters and my dad and I had a huge list of when we were giving morphine, when we were giving this lucid drug to keep her mind calm, because my mom was on 19 medications before she got cancer. So when she went from palliative care to hospice care, they got her off of everything. You know what withdrawal is like. So on top of going through death process, she's withdrawing from drugs. And I'm the one having to determine if she got enough of that morphine in her mouth, or enough of this drug, or if she needs more by, is she clenching her teeth? Is she shaking? Like, I'm looking for these symptoms that they're telling me I'm looking for. And this is why I'm not sure she didn't have a painless death, especially what happened at the end. I won't forget that. I really truly felt like I watched my mom drown and she was looking at each of us. But as I said, I'm not a qualified doctor. We never had a doctor come to our house in hospice care. It was qualified nurses, and they were great. I don't want to diss hospice care at all, but an hour every other day. And also, oh, one more thing. There was an emergency situation. My mom could not get up. Basically, she was sent to hospice care on a Friday. And by Sunday, we had an emergency situation. She was having trouble getting out of bed. And that hospice nurse basically told us she's not to get out of bed anymore. That was the 20th. She dies the 27th. That day, I helped the nurse insert a urinary catheter. Many times during the week, my sisters and I inserted suppositories. My mom never did that again between basically getting into that bed and dying. And I had to hear my mom, when she was still able to talk, cry, saying, all I want to do is get up and go to the bathroom. All I want to do, and she could not do that. There was no nurse around to help, no nurse to add more morphine. We had to do all that stuff. So hospice care, I think, until people are really there, and again, this is hospice care at home. Some of the doctors that talked about how they give such great pain relief, I'm like, are these people in the hospital? Because my mom was not at the hospital. My mom was at home, and I never saw a doctor. And so when they're like, oh, we'll just pump more in, she never even had an IV set up. It was all through her mouth. Are there any other palliative care questions I can answer for you?
Well, we have a bunch of people who'd like to ask you questions, given an opportunity. We'll start with Representative Linehan, followed by Representative Gilchrist.
Okay.
Thank you, Mr. Chairman. Hi there. How are you? I know that we've spoken over messages before, and this is really our first time talking directly about this. And I want to thank you so much for your passion and your fire, and for coming here today to talk about, you know, the really difficult time that you had. And I think that you painted a really honest picture of what it looks like to watch a loved one pass. And I'm so sorry that that happened to your mom and your family, but I'm also very thankful that you're here today to talk about it, because you're really doing great work to help others. And the story that you just told about her end of life care, it really wasn't the wine and roses that we're really led to believe it is. I mean, isn't that an easy way to sum that up?
No, I would agree. Even that death rattle people talk about, I didn't realize she was starting that death rattle the night before, and I still carried guilt because there was a specific medicine I was supposed to give when that death rattle was supposed to come. It was like lorazepam. I don't remember which one it was. And it was like, when you hear this, start giving that. Well, I never gave it to her that night. And then the next day when I went to school to teach, my sister was like, did you hear that noise? I'm like, yeah. She's like, that's the rattle. And I'm like, what? And then I feel bad, because then the nurse did come and said, yes, that's the rattle, and your mom has hours to live. So I felt like I failed her in treatment. I'm not a doctor. And yeah,
that's
I know
a lot of pressure for a loved one.
Right. And I know what she wanted. And you know, when the nurse told us that she was no longer to give her own medicine, I knew instantly what she was thinking. And she could express her thought then, that I just lost my way out. Because she even said when she got diagnosed with cancer on that August 2nd, the doctor gave her 20 oxycodone pills of some sort. And she said, Kristen, this is my exit ticket. And then when she was about to go to chemo, they gave her 120 more. So you see what I'm saying? She had 140. I put 100 in my testimony because I wasn't quite sure, but I'm pretty sure it was like 140 OxyContin pills on top of all that morphine. She could have gone, but they took that away and they put it in our legal hands, and I cannot break the law.
So this is very similar to what we heard in Dan Diaz's testimony. And I specifically asked him to point out the differences between actual suicide and dignity in dying. And one of the things that he said, and he listed many of the differences, and I think they're very clear and very important to hear. But one of the things that he said is the family that you leave in your wake. And when you die by suicide, it's incredibly heartbreaking for the family, and you leave them mourning in a way that is much darker than if your family knows that you have helped them end their life in a way that has dignity and respect in the method of their choosing, so that they're not in that end of life care that you just described that was painful, not only to your mom, but also to your to you and your sister. And so I thank you so much for that testimony. And I read your testimony a week or so ago, and it's been sitting with me ever since. And I really would ask my fellow committee members to really go back and read your words. They're very powerful. And I thank you so much for being here. And I thank you for being brave enough to speak tonight.
When you mentioned Dan, he also said something about like suicide versus the assisted medical aid and having stuff to look forward to. And I originally thought my mom wasn't even going to try chemo because I thought, because there was no, this is not a cure. This was palliative care. And I was actually quite shocked she decided to even try. And I know why she tried, because in the next, she knew she wasn't going to live to Christmas. I knew it. But in November, it was my sister's 40th birthday. And I was due to give birth to my second child in November, who now bears her, they share the same middle name. And I think that's why she tried the chemo, and it rapidly failed her body faster. Again, the tumor in August was 10 inches, and then it grew so much faster. So I feel like that's one of the differences. And you're right, much darker funeral suicide. There was no one in my household that would have disagreed. No one, you know something, we also cremated her body. Do you know when you cremate someone's body, all the next in line relatives have to agree upon it? So for example, if my father was to pass and we were to cremate him, all three of us daughters would have to agree upon it. If one of us didn't, by law, the cremation can't happen. We all agreed that we supported her end of life if we could get medically aided death, but we couldn't get it. And I'm upset that this is now third time or fourth time this bill is coming up. And people are saying COVID, we shouldn't be, are you kidding me? This is the best time to be talking about it. COVID people do not get this opportunity because it's such a sudden thing. This is very specific, 6 months or less, terminally ill adult. This is the best time. We failed my mother, but let's not fail others. Let them have the choice. And we're only talking, was it 6,000 in the length of the bill in all 10 states and 4,000? We're not talking about a large number, but it mattered to my mother. Thank you.
It does. Thank you very much. Thank you, Mr. Chair.
Thank you, Representative. Representative Gilchrist, followed by Representative Zupkus.
Thank you, Mr. Chair, and thanks, Ms. Kiska. I agree, you are very direct and very honest, and I really appreciate it. And I'm sorry for what happened to your mom and what you all witnessed and had to go through. I am gonna do what you said. So you have been mentioning, which I really appreciate, all the drugs that you were given, and that, you know, you could have taken it into your own hands. But I appreciate you saying, but we wouldn't know if we didn't. So I want to know what did happen with all the drugs, because that's been an argument being brought up, like that somehow this medicine would end up on the streets. What happens to the drugs?
Okay, so my mom passed at 2:48 per our time. That's after she went through that event. By the time the hospice nurse, I forget, she probably was an upper ranking nurse. I don't remember codes, but she's basically like a doctor. We called her and she came to our house by 3:15 or so. She pronounced her dead. And literally the next step was, I have a bag of kitty litter for you. You must touch, by law, the hospice nurse, or at least what she said, they can't touch the morphine or the Oxycontin-like pills. And she literally said, go find all the medicine and let's dump it out. And she watched me dump it out into the cat litter and kept track, like a list of everything we dumped out. And we did, to be honest, my mom, as I told you, had 19 prescriptions. We dumped out everything. Actually, I primarily did, because to be honest, my mom, we kept her in the house for a few hours so people could come visit. So while my sister and my dad, I went into cleaning mode. That was my sanity. I instantly went to cleaning mode. So everything got dumped in kitty litter. And Dad, it went to our garage, our trash can, right?
It didn't go to the trash can.
No, no, they didn't take. I swear they just told us to put in the trash can. So we're disagreeing. I think it was the trash can because it was in kitty litter. So it was supposedly destroyed because it was in kitty litter. And that's what happened to all those drugs.
Thank you. Thank you. I appreciate it.
Mm-hmm.
Thank you, Representative Zupkus.
Thank you, Mr. Chair. Hi, thank you for coming in. And I do appreciate your passion. I can imagine, because I'm passionate about my mom and dad as well. So, and I know they're proud of you for doing that for them. So I'm going to ask you my question about marijuana, but first, It's interesting. You were just talking about kitty litter. I tried to get a bill passed a couple of years ago to be able to dispose drugs either back to a pharmacy where they come from, and got so much pushback it never went anywhere. And when I questioned it, they said put it in kitty litter. I'm like, who knows about kitty litter? I mean, this is
they brought it for us.
crazy,
You don't have cats, we have
right?
dogs.
But it is true. But who would ever know that, right? And what if you don't have a cat and all of those things? So anyway, I wanted to mention that. And again, before I ask you the question about the medical marijuana, you made mention that the hospice nurse came to your house an hour every other day.
Okay, so when it first started, it was like they did the whole setup. So they took a little while that day to set up. So they had to get a medical bed, and they had to go through all this paperwork with all of us. Basically, 3 daughters were there. My dad was there. But once we got set up, it was only if we had an emergency call, like when I had to put in the catheter, or I think it was 3 days in the beginning. But remember, my mom only had like a week, so then it was like every 2 days, and then it became every day. It was not. I would have expected them for like when I had a C-section that opened up. I had a visiting nurse twice a day cleaning that out. I had more, she was there shorter period, but I had more visits than my mom did for when she was dying in the last few days.
I would be curious why that is, because I wonder if it's for insurance, what they cover or what.
As I said, my dad could test. I don't think my mom's insurance was good. Like, Dad, did you pay anything?
Our cost was very, very low. It was my insurance.
My dad's, he says the cost was very low. So co-pays
Right.
for everything.
Okay.
So.
Okay. So now I'll ask my question.
That
about-
hearing was today too. I couldn't double dip on the hearing. So.
It's still going on if you're interested.
No, I think I can say my piece here.
No,
Go ahead, ask the question.
So not your piece, just I'm curious, would have, medical marijuana helped ease the pain? For your
So here's what happened. When my mom first got diagnosed, my mom all my life had told all of us, and it was a great anti-drug commercial that she once told us she was allergic to it. I swear she said that. But she really hated pot. She was like, never bring it in the home. I don't like it. So I can attest that my mom never, ever, ever did marijuana. At least she was a good liar if she did, but my mom can't lie. Remember, I told you to tell the truth. So when my mom was not feeling well and they gave her those 20 pills, she's like, I have pain. It's discomforting, but it's because it's not like that discomforting. And so without naming names, a family member was able to get my mother some gummies. And we took one of those gummies and we gave it to her. And she basically said that was the relief I was looking for at that moment. She basically said she had her pain in her belly was the equivalent of the worst menstruation cramps. This is remember, this is August, menstruation cramps you could have. And that was the equivalent of solving that problem. So then she was using just the smallest. I think I ended up cutting them up at like 5. They're like cutting them in half. So she was taking like small pieces. So when she was about to have chemo, I remember this on September 3rd when she went to see the doctor and he gave her that prescription for 120 oxy something. She started the paperwork for medical marijuana. And so she had to go home, fill out paperwork, bring it back on Monday to the doctor who had to sign off on it and send it off to the state. And she was supposed to wait for an email to get approval by the state board. So she got 120 pills that she could use to kill herself, but she couldn't get marijuana on that same day. And she never got approved before she died. And that was my issue with the medical marijuana. She needed it, she wanted it, but she could get a highly toxic drugs, but could not get something that she already knew would work on her belly.
Maybe that's something we have to change that law. We have to look into that law because lawmakers made that law.
I know, and I just couldn't understand why she couldn't instantly get that for how rapid her stuff was, but yet she could get the 120 pills.
Interesting. Thank you for sharing that with me.
You're welcome.
Thank you, Representative. Representative Clara Distria.
Thank you, Mr. Chair. Thank you, Kristen, for coming here today. I'm sorry about everything you had to go through with your mom. My question is, one of them, why did you choose to have hospice, and you may have answered this, in your home versus in the hospital?
It wasn't my choice, it was my mother's. She wanted it at home. I feel like she didn't want to be surrounded by the doctors. Dad, do you have any more comments about why she chose it at home? The comfort, being around family.
Family being around her.
I don't really know, actually. That's a great question, and I wish I could have asked my mom, but I know she wanted it at home. But my mom was also very much wanting to be part of the process, even so much so that I told you on the 3rd that we went to, she had chemo that weekend. She planned our funeral with us. Like, we went to the funeral home together. So I cannot remember, other than the fact she probably wanted to be at home, away
Okay.
from the buzzers and not having us have the burden of people having to go to a hospital, because people do think of burdens when they're about to die.
And how long did she have hospice at home?
Okay, so she had chemotherapy on Thursday the 11th. By Sunday, she already knew she wanted to die, because she confessed to that me later. We saw the doctor on the 13th, so the Thursday the 11th. She went into hospice on Friday the 20th. And so she went from going from palliative care, because once the doctor's like, once you do hospice, you're done with us. That's what her chemo doctor said. So on Friday the 20th, she was officially in hospice, and she died on the next Friday, the 27th.
Okay. All right. Thank you. And I do believe we need to make some changes to our medical marijuana program. I think that needs to be more accessible and to your point, like you said, faster than people are getting it right now. But thank you so much for your testimony.
Thank you so much. Thank you for listening.
Chair.
Thank you, Representative. Kristen, thank you for your testimony. We have no further questions for you. We've covered a lot of ground. Thank you and the whole rest of your family behind you. Have a great night.
Thank you so much.
Next up is number 98, Sarah Lyston, I believe, followed by Karen Shields Wright. Dr. Karen Shields Wright.
So, hello, I hope you can see and hear me all right.
We certainly
My name is
can.
Sarah Lyston, and I'm here talking in favor of the proposed House Bill 6425. I have a very similar story to Kristen Teska's, only mine was accelerated 6 times as fast with my mother. As far as I'm concerned, the proposed bill is actually too strict. I think the safeguards in place are appropriate and maybe even a little too overreaching. My mom was in full remission in January of 2015. At the end of February, she felt fatigued and went to the hospital and was given 3 to 4 weeks to live. The cancer was so aggressive. After 2.5 weeks, my mom stopped eating. The tumors overtook her body to the point that her skull became lumpy. The tumors protruded from her back. Her abdomen was swollen with tumors. My mom laid in a coma for longer than 7 days while we nursed the tumors and kept alive the very thing that was killing her. And I'm not going to sit here and pretend what my mom would have done if she had the choice, as we're proposing, but that choice wasn't given. She had the choice between dying in a hospital with strangers or dying home with those she loved. And we took care of her because we loved her. But unfortunately, love isn't enough in cases like this. And I think that's really what we're asking you to look at in terms of helping people in their final time here on earth and helping to make a decision that's crucial for them and their family. What I witnessed and what I saw my mom go through, she would not have wanted that. She would not have wanted her 2 children, her pride and joy in this world, to see her like that, to care for her like that, and to wait as she lay dying. My biggest concern is everyone says palliative care, we can provide all this protection and, we can help ensure you're not in pain. Prove to me my mom wasn't in pain. She would clamp her teeth. Hospice nurses said that meant she was in pain and to give her more morphine. But the little gadget actually limits how often you can give the morphine. So she could clamp her teeth as much as she wanted, and we would be restricted to how much morphine we could give her. And as Kristen said in her testimony, the hospice nurses would only come once a day if you called them on emergency, and they were fantastic, but they were limited too. And I really think it's time that in the state of Connecticut, we let patients be the decision makers in how they live their final days. This is not suicide. This is knowing the end is near and choosing not to be in pain. This is choosing in your final moments to express your free will. It is your choice on whether or not to wait the extra 5 days. So I hope I encourage all of you to vote in favor of this bill, as it provides the first step, really the first step in helping patients and to really get that decision back. And as
Thank
always,
you.
I welcome questions if you have them.
Thank you so much for your testimony, Ms. Lyson. I really appreciate it, and for the story. And your mom was certainly lucky to have you there for her. I
Thank
don't see any
you.
questions, so thank you so much for being with us tonight.
And please check my written testimony as well.
We will. Thank you for that. Next, we have Maxwell Fay, followed by Jennifer Mazzoni. Maxfield Fay.
Hey everyone, can you hear me?
Yes, please go ahead.
Great. Good evening, Public Health Committee. My name's Maxfield Fay, and I'm here in support of House Bill 6425. I grew up in Farmington and only recently moved to New York to pursue a career as a lawyer. I actually just graduated from UConn Law, and I love everything about Connecticut, except that you haven't passed this bill yet. That's the only thing. So anyways, I support House Bill 6425 because I have personally seen how ugly death can be and the necessity of having it controlled out once someone receives a terminal diagnosis. I've been to a few of these before, and I'm well aware of the time constraint of my testimony. And like many others, I'd like to get straight to a personal anecdote that may shed light on the necessity of this bill. But before I start, I think it's important for all of you to note that the harrowing stories we've heard today could have been prevented with the passage of House Bill 6425. And by voting to pass it during this legislative session, you're doing your part in protecting Connecticut residents for years to come. 9 years ago, I lost my father to a long battle of prostate cancer. He was the epitome of dignified until the very end of his battle, when the cancer reared its ugly head and threw him into a painful fit of discomfort and agony. His last day on this earth was painful to witness. As a 19-year-old, I sat at his bedside, squeezing his hand, and witnessed the last thing he ever wanted me to witness. My last memories of my father consisted of him yelling in agony, squirming in discomfort, and bleeding out, completely immune to any amount of medication that wouldn't render him unconscious. Keep in mind, this guy was a fighter. He fought prostate cancer for 17 years, and many people discovered that only by reading his obituary. Some of you even knew him personally. Because we didn't have a bill of this nature in place in 2012, Connecticut forced a 19-year-old to watch his father die an agonizing death against his will. And this was preventable. And it still is preventable for those who have loved ones in their lives. And you are the solution, because without your approval, Connecticut residents are unable to utilize this medication. And until you do something, these harrowing stories are going to continue to proliferate. By voting to pass the bill, you're allowing our terminally ill population to die with dignity if they so choose, and allowing their loved ones to witness their send-off on their desired terms. Because ultimately, death doesn't have to be ugly. That's why this bill is selfless. It seeks to bolster the autonomy of our Connecticut residents by allowing them the choice of ending their life when a terminal illness rears its ugly head. It's selfless because it doesn't force anyone to do anything they don't want to. And I'm not pulling that out of thin air. There are 0 cases of abuse, misuse, or coercion in the states that have taken the lead in passing a similar bill. We're fortunate to use these other bills as reassurance that this is what's right and this is what works. So for those of us who want this, and believe me, there are a lot of us, give us the freedom to make one of the most important decisions of our lives. And in doing so, let's prevent other Connecticut residents from having to endure what I did. Thanks so much for your time, and best of luck during your deliberations.
You're going to be in the picture.
No,
you are. You're right behind me.
Excuse me, can you please thank Mr. Fay?
Hi.
Hi, thank you. Thank you so much for your testimony. Congratulations on your graduation from law school. I wish you could have stayed in Connecticut. So thank you for taking your time to be with us tonight and to share the story of your father. I'm sure he would be very proud of you.
Thanks so much for having me.
Thank you. Have a good night. Next, we have Jennifer Mazzoni.
Hello, can you hear me?
I can. Go right ahead.
Okay. Members of the Public Health Committee, my name is Jennifer Mazzone from Orange, Connecticut, testifying in support of Health Bill 6425. You might recognize my last name as I'm the widow of Mike Mazzone, who testified before the same committee on similar legislation in 2018 in support of aid in dying. My proud, loving husband, MMA fighter, union representative, triathlete, felt forced to plead before this same committee just a year before he passed. There was no vote. He suffered and died. It was not at all how he wanted this to go. He was living with ALS. Each day was a struggle, but he fought hard to advocate for aid in dying. His words at the time he testified: "My doctor tells me I have 2 years left to live, as this disease slowly takes everything from me. I will slowly die of asphyxiation. There's no cure for what I have. The progression of this disease on my body is inevitable. It's a constant nightmare." I'm here before the committee in 2021 to let each of you know that he was right on both accounts. And on July 15th of 2019, struggling for each breath, Mike died of asphyxia, and it was a nightmare. It's important to me to make sure that you know that he suffered unnecessarily, as the reasonable option of aid in dying was not afforded him. You may hear testimony from doctors and healthcare providers that all pain can be addressed for someone who's terminally ill. I have seen firsthand this is simply not the case, in spite of their best intentions. Mike leaves 5 beautiful kids of whom he loved dearly, and each one deeply feels his loss as I do every day. He also leaves behind a legacy of advocacy on this issue, which brings me to these points. Laws such as these have been on the books for over 20 years now without a single case of abuse proven to be caused by aid in dying. In poll after poll, nationally and in states, by overwhelming margins, Americans support aid in dying. And in 10 states have passed the law, most recently Maine and New Jersey. So I asked this committee, why does someone with ALS in Orange, New Jersey have more options at the end of their life than in Orange, Connecticut? I have a deep Catholic faith, and based on my life experience with Mike, I often wonder if medical intervention is used to prolong life, then why can't those same interventions be used to ease suffering for a terminally ill, mentally capable person at the end of their life? When a terminally ill person is faced with death, as Mike was, having an option to peacefully end that suffering is its own form of grace. I was with Mike when he came before you in 2018. If he were here today, you would ask the legislation to do their job, to act to ease the suffering of people faced with the same illness he had. No longer for him, but for others. Please vote in support of Health Bill 6425. Thank you.
Thank you so much for that testimony, and I'm sorry for your loss, and I'm sorry that your husband was before this committee and never got to see fruitful results of that. So there is a question from Representative Tavros DeGraw.
Not actually a question. I just wanted to comment. I'm new to the committee, and so each and every one of these testimonies is really helpful to those of us who are new to the committee. And I'm sorry that I was not here to hear your husband the first time, but I want you to know that I'll be thinking about it for a long time. So thank you.
Thank you.
Thank you so much for being here tonight. We really appreciate it.
Thank you.
Next is Stanley Greenberg, followed by Lori Bruce. Mr. Greenberg, you're on mute.
Okay, how about now?
You're good. Go right ahead.
Good. I commend the committee members for their stamina today. I speak in favor of House Bill 6425. I submitted written testimony. I prepared oral testimony, but considering how long today has lasted, I'm going to make that even shorter now. There's been more than 45 collective years of experience with medical aid in dying, and it has been shown to work exactly as it was intended and without the dire consequences that were warned of by opponents. So wherever it's legal, it has not caused any problems. That is really big. The conditions in the bill are rigorous, they're numerous, there are protections as well. And the committee knows them very well. So I'm not even going to start to go through any of those. I'm doing what I can to be merciful when I'm speaking of aid in dying. So I'll make only two final points. One is, this is about autonomy. It's about a person's right to exercise some control over his life when the end is in sight. That seems more than right. The second point is, an aid in dying law doesn't force anything on anyone. Also very important, it just ensures that those who qualify for it won't be deprived of that option. And to me, that's critically important. And that is really all I need to say.
Well, thank you very much for being succinct. It is a late hour and it has been a long day, but everyone's testimony, excuse me, sir?
Oh, that's very unusual for me, as everyone who knows me will attest.
Well, you can tell them I've been a witness to it. So if you ever need that, but I want you to know that even though you were brief, it's meaningful what you shared with us, and I greatly appreciate you being here tonight and offering your testimony. So thank you so much and have a wonderful night.
You too.
Next is Lori Bruce, followed by Michael Tucker. Lori, go ahead, please.
Good evening. My name is Lori Bruce, and I'm a bioethicist at Yale's Interdisciplinary Center for Bioethics, and I'm a resident of Hampden. For many years, I was quite skeptical of legislation as proposed in this bill. However, I do support this bill. When we examine common ways of dying, ways that are socially accepted, legal, and ethically permissible for adults with competence, we see that many people already have a say over the manner and duration of their final days. For instance, patients have the right to stop dialysis even though it knowingly causes their death. Dialysis can be hard and intense and painful, and some people do not like living that way. Physicians and others can counsel them on their options, but it is the patient's right to decide. And 25% of deaths in patients with advanced end-stage renal disease are because they chose to stop dialysis, knowingly ending their life. Similarly, patients have the right to withhold or withdraw their ventilators or feeding tubes or other interventions at end of life, or to go to hospice, perhaps curtailing an invasive or painful treatment. And many people do indeed choose to be comfort measures only at end of life. Another example is the right of a patient to have their heart implant removed when they are ready to die. And in a recent survey, 92% of physicians who manage the treatment of patients with implanted cardiac devices have personally deactivated an ICD, and 77% have deactivated a pacemaker. So these three paths that I've described are all legal, even knowing that they curtail days, weeks, or perhaps months from a person's lifespan. These patients are not suicidal. They wish they could live longer, but they are actively dying. They are out of options. And they are permitted to change the course of their medical treatment with the physician's intervention. And they and their physician are well aware that this intervention will result in ending their life. Patients who seek aid in dying also wish they could live longer. They too are not suicidal. They are actively dying. This Aid in Dying bill is a way of offering equal treatment to people whose dying process just happens to not neatly fit the other biological pathways that I described above. This law should be passed, and it should be designed and implemented with transparency and inclusivity. And like any medical practice, data must be collected and regularly inspected by an inclusive interdisciplinary community advisory board to ensure ethical implementation. I thank you so much for your time today. And if you have any questions, I would be delighted to address them.
One question that I have, Ms. Bruce, is did you put in written testimony?
You know, I haven't yet. If it's not too
Okay.
late,
No, I'm asking because that was a lot to take in. I was not aware of what you just spoke about. And so I wanted to go back and read it over because I was not aware that there were, legal processes like that physicians could do with their patients that, hurried their end of life, I will say. So, this is the first time I've heard of that, and so I thank you very much for sharing it. Representative Foster.
Hi, thank you so much for speaking with us today, Dr. Bruce. So I'm curious if you might be able to, with your expertise as a bioethicist, help us sort of understand, for those of us who are having a hard time with this line, that there seems to be, as you've said, some things that we're allowing that would hasten death, that are in fact hastening the process. And there seems to be intellectually, philosophically, a line for folks. Can you help us navigate if that line is true, that it should exist, and then if it is a line that we've crossed, then what else should be like clawed back if we believe this isn't possible? Like I feel like we've sort of gotten into this conversation, and the more people who have spoken, the more it's become clear we actually already allow some things that hasten the end of life. This seems to be one that offers dignity in that process where some others might not, but the actual hastening of end of life, which is I think a lot of people's common concern, is permissible in other settings. So can you sort of talk about that from like a bioethics standpoint?
Sure. And if I don't address any subparts, please let me know. In terms of hastening, there are so many protections in this bill that really it makes it very clear that patients really are at end of life. And so the worry about hastening is really, in my view, not founded. And that's why I've demonstrated, with these other methods that are very common pathways to dying, that these are all, that it's already, so many other patients already have so much flexibility. This is well known within medicine, within these other approaches to these pathways to dying, that this is what happens. And patients do already have kind of this bit of wiggle room to say, I'm not interested in trying to, win some competition for the number of days I can eke out here. Life is about more than just the number of days I can eke out. It's about, how do I want to be able to craft this dying process, because I know I'm going to die and I want to live longer, but that ship has sailed. And now that I'm in this position, how is it that I can find a way forward to kind of craft my own legacy in a way that isn't really scary or painful for me? I hope I've addressed your questions.
You have, and another thing that I'm curious about from a bioethics standpoint is it seems to me like some of those other options that exist are not only hard for the person who's choosing them, but particularly hard for loved ones watching. And this one, in part of the dignity in it, is that it is something that, because of their control, it can feel less scary for the person experiencing it, and that could allow them to prepare their family and loved ones in a way that they wouldn't otherwise, and that promotes dignity of the person who's suffering at the end, for them to be the one who's making the decision. Can you talk about that a little bit?
Absolutely. And I think something that's really interesting, and I'm just bringing up the data point so that I can speak absolutely with accuracy here. But I think what's really interesting is that in Oregon, where aid in dying, of course, is legal, 1 in 6 terminally ill patients talks to their families about these issues, and 1 in 50 asks their doctors about their willingness to provide it. And then 1 in 300 patients who initially inquired actually receives the medication. And then about 1/3 of those who do receive it, that medication never really take it. And so what's so interesting about when these laws are passed is that it helps people talk about their options. It promotes discussions between patients and their physicians. There are so many families that are now engaging in conversations with their loved ones to say, you know, there's this option out there now, but I don't know. And so many of the families don't even go to their doctor about it, but it has facilitated this question. And you know, this dying is when a loved one dies, it is so hard for their loved ones, you know, regardless of what option they choose. And death isn't something that we talk about much in our society. And I really have to commend all of you. I mean, I talk about death and dying and all sorts of ethical conflicts at the bedside all the time, every day. And I've just been so impressed with how all of you, you know, are engaging in these issues with such impeccability, such wonderful questions, such you know, real desire to kind of get this right and understand the issues. So I commend you all for that. You know, so much of my work involves being on the receiving end of helping to solve and mitigate ethical conflicts that come up, and often in the hospital, and often those are about dying. And sometimes, you know, when there is a patient who is saying they want to go off of dialysis, we will sometimes be called in because sometimes the physicians aren't really sure what to do, or they just want another person to be a part of this, and they want ethics to be involved. And so there are these ethics committees that I serve on that help to navigate these issues. And you know, I think what's so wonderful about the Aid in Dying bill is that there are so many levels of protection built into place, but there's so many conversations built into this. And there's so much to help facilitate the dialogue and to promote training and to promote the ability for all of us to start engaging more within our society, to start, you know, being a little bit more comfortable with these very hard questions.
Thank you very much.
Thank you, Representative Foster. Representative Pettit.
Thank you, Madam Chair. Thank you. Mrs. or Dr. Bruce?
You can call me Lori. It's just fine.
Mrs. Lori. A quick comment. The discussion on therapies, a lot of it has to do with intention. The intention of a lot of the infusions, the sedation has to do with relieving a symptom, typically pain, typically dyspnea, typically discomfort of some point. The reason for starting it is not to induce death. Secondly, you deal with semantics and word definitions all the time. And I'm wondering if you distinguish the examples you gave all involve withdrawal of therapies at a time when circumstances have changed, as opposed to a much more active therapy by giving a medication at a dose that you know is going to induce death. So I view them a little bit differently, a withdrawal of a therapy or stopping of a therapy versus starting a brand new therapy with a very specific intent. Anybody who's been in practice long enough has had someone in the ICU who was taken off a ventilator he thought was going to do poorly and maybe die, and they shock the heck out of you and walk out of the hospital a week or 2 weeks later, and you're amazed that it happened. So I wonder if you comment on the difference between stopping a therapy when situation have changed versus an active therapy. You're sort of equating them, and I don't really believe it. In my head, they're not equivalent.
You know, I have to say that anytime there is a dialogue about stopping, whether it's stopping dialysis or removing a cardiac implant, that is a major intervention. That is something that is approached with such caution and so much process, and so many people are in the room to help guide that decision, and so many discussions take place that I'm sure the patients and families are never aware of, but we bring in so many people from a very interdisciplinary approach to really get all perspectives and make sure that, you know, if a patient, for instance, is, you know, saying that they want to stop dialysis, that isn't something that's just kind of a passive decision. All of the pathways I described involve many steps and lots of work that's maybe behind the scenes, but many conversations where physicians are talking to the nurses, are talking to the ethicists at the hospital, are talking to the chaplain, are talking to the family, are talking with the patient, are engaging with the primary care physician, and so on, to really gain a deep sense as to whether or not that stopping or that removal should happen. And so I regard all of the pathways that I spoke about to be very much an intentional decision that requires a lot of thought and a lot of deliberation. So I hope that that's kind of helpful to you.
No, it is. They're not simple decisions. And I think off the diagnosis of a cancer or something terrible is very obvious, whereas a person whose quality of life has slowly declined on dialysis or with a pacemaker defibrillator may be more subtle, and the outside world may not perceive it, and the patient may perceive it first and reach out to their physician, their nurse, whoever they're talking to, and say, you know, this isn't working for me anymore. So maybe a little more subtle, but your point is well taken. I thank you for your comments. Thank you, Madam Chair.
Thank you, Representative. I don't see any more comments, so I'll thank you very much for your testimony this evening and appreciate you taking all of our questions. Thank you for being here.
Oh, thank you so much. And if I may just say one final thing, that there's been so much talk of abuse, but when we think about all of these options that I've described already that have hardly any of the checks that are in the proposed bill, we are not aware of any widespread evidence of coercion related to any of those other methods. And I think that speaks to the integrity of the medical system. And I think that really speaks to the need for oversight. But I will stop talking. And
thank you. Yeah, I have to stop you there because thank you so much for being here. Next is Michael Tucker, followed by Stephen Lyon.
Hi, am I there?
Yes, Mr. Tucker, go right ahead.
Thank you very much. My name is Michael Tucker. I live in Easton with my wife, Jill, and we're actors. And a couple of years ago, we received a life lesson in dying from a dear friend of ours, the wonderful actor Rene Auberjonois. He had gotten a diagnosis of stage 4 lung cancer. And when he called us to give us the news, I got very emotional about it on the phone. I said, "We're not dead until we're dead, Rene. Don't forget that." I was saying this to him and to myself, of course. We don't die in increments. We're alive until we're not. So your responsibility to your wife and your children and to their children and to yourself is to live. And then after you die, you won't have to worry about that anymore. Well, he, of course, knew all this. He and his wife, Judith, planned a trip to Ireland with their kids and their grandkids. His sister and her family lived there on a farm, a beautiful Irish farm, and they all leapt into that adventure together and spent about a month there. And then Rene and Judith went to Buenos Aires, where they had never been, and they learned how to tango. And one of his incredible talents was photography, and he sent me a photo of tango dancers that he had hand-painted. I don't know if you can see that up there. And on the back of it, he quoted Leonard Cohen, the poet and songwriter. who said, "Dance me through the panic till I'm gathered safely in. Lift me like an olive branch and be my homeward dove. Dance me to the end of love." Thankfully, Rene did not have to suffer needlessly at the end of his life because he lived in California, where medical aid in dying is an option for terminally ill adults to die peacefully. So in the last weeks of his life, he combed through nearly 60 years of photographs and put together a slideshow for the family. They all gathered at his bedside and watched the history of their life together, with Beatles music blaring merrily away. It took hours to see it, and they laughed and they danced and they hugged and they cried. It was like life. And then, with everyone gathered, he took his aid in dying medication and peacefully died a very loving death. And one of the last things he said was a thank you to the state of California for allowing him to die with the option of how it would proceed. He lived as he died, as an artist. Now, I have no idea how or when I'm going to die, but I know that if Connecticut passes this medical aid in dying bill, then my life now will be better. I urge our lawmakers to pass this compassionate legislation this year because terminally ill Connecticut residents have no time to spare. Thank you.
Thank you so much for your testimony. He sounds like an amazing man, and you sound like an amazing friend. So thank you for taking his memory and turning it into something positive, and your advocacy for this bill. There are some questions for you, Senator Wong.
Thank you, Madam Chair. And Mr. Tucker, thank you very much for your eloquence. And I know you wrote an op-ed along these same veins. And I know Jim Naughton mentioned Renee's name.
Mm-hmm.
You just described an individual who knew that they were going to pass. But instead of what we've heard in some parts tonight about palliative care and trying to ease the pain and the suffering, you shared a story of somebody who had control and decided to know how to manage their affairs and celebrated life. That touched me. Can you elaborate a little bit more of what it meant to you?
Well, I'm 76 years old, and I'm thinking forward to my death, which will be however long it is from now. I don't know. But I want to be prepared. I'm very, 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 very concerned that when I go, my wife is not going to know how to work the remote on the television, and she'll have to spend the rest of her life watching the Golf Channel. I have all these things to take care of before I go, and one of them, the great thing about what happened to Rene, or what he created there, was my wife and I are still very in touch, closely in touch with his widow Judith, and also with his children, whom we've known since they were born, and they're in their 50s now. And what he did, that thing that he created, truly helped them grieve after the fact, because they all experienced a very positive and beautiful thing. It was very different from watching someone suffer. And this was something he very much wanted to do before he died. So, it's why I'm here talking to you people who really work hard. I had no idea your days were like this.
Into the night.
And yes, into the night. I'm very impressed. But I think it's very important to me and to my family that we do have some sort of control over it if we can. I may die suddenly, and then this is all moot. I won't have choices and I won't have options. But if I do, it would be wonderful to have this option.
Well, and I appreciate that, and your eloquence in honoring a friend. is something that is touching, and I'm sure that his family appreciates it, and I know I appreciate it. I will leave on a bit of a humorous note that in your op-ed you did talk about the remote control dilemma, and you made me laugh because we have the same problem in our own house. So again, it's been a long day, but I appreciate you sticking it out with us and sharing the story. And I find it interesting that as you talk to people that are in favor of this, that in giving them the chance to control their life, you've given them some autonomy and control. Kind of statement. So thank you very much, Mr. Tucker, and my best to your lovely wife. And thank you, Madam Chair.
Thank you.
Thank you, Senator. Representative Berger Gavallo.
Thank you, Madam Chair. Mr. Tucker, I was actually going to ask you about something that you just addressed, which was about Renee's wife and children and what they shared with you after. But now that you've answered that, I will just share with you the most insane coincidence, and that is at 1 o'clock this morning when I couldn't sleep, I put on a 1971 movie and was very excited to find that not only was it Renee Auberjonois in this film, but it was also Leonard Cohen doing the soundtrack. Such a very strange thing. That was McCabe and Mrs. Miller.
Yeah.
And it was actually a piece of art, that film, but I'll talk about that with someone else at another time. If there's anything else that you want to add about his family, anything that you think that we need to hear about how they were after that decision was made, I would love to hear that.
I would just simply say that his family has never been as close as they are now. And I think it had a great deal to do with that, with the way he died.
I think that is just all I needed to hear. Thank you very much for that.
Thank you.
Thank you, Madam Chair.
Thank you, Representative. Representative Steinberg.
Thank you for your testimony. I thought I just had this one question that is going around and around in my head. And it's probably not all that relevant, but I really have to ask. When is there going to be an LA Law reunion?
I don't know. There's always been talk about it, but I don't know. I think young people should be doing it if there is. I don't know.
Maybe you can get to pick who plays you when you're.
Yeah, wouldn't that be fun? Yeah, a very handsome young fellow. Yeah.
I'm sure. Sorry, that was way off topic. Sorry.
Thank you. And I'd just like to thank all of you for the work that you do. You represent us, and that's a very important thing, and I thank you for it.
Thank you. Representative Clara DeStitria.
Thank you, Madam Chair. And I have to go off topic quickly too. Michael, thank you for your testimony. Loved LA Law and loved your wife, Jill. And thank you for years of entertainment. God bless. Thank you, Madam Chair.
Thank you.
Thank you, Representative. I just want to say, Mr. Tucker, before you go, that I was also moved by something that you said, because there have been some comments throughout the day about why would we do this bill with everything else going on. And believe me when I tell you that the Public Health Committee has a very wide range of issues that we're taking on this session. But we felt that this was an important one. And your statement about how important it is to those people in our state who are now suffering from terminal illness, and that waiting on, for them would be a real disservice. So I appreciate you pointing that out, and I thank you for that.
Thank you.
Thank you for being with us tonight, and have a wonderful rest of your evening.
You too. Thank you.
Next, we have Stephen Lyon, followed by Sharon Hines. Mr. Lyon, go right ahead.
Good evening. I'm speaking from my car right now, so I hope you can hear me. Can you hear me all right?
We can see you and hear you fine. Go right ahead.
Oh, all right. Thank you, Senator Abrams, Representative Steinberg. And I just realized in my written testimony, I misspelled your name. My apologies. It's 11:03 p.m., so I will try to be brief and let you follow and read my written testimony at a later time. I'm just going to highlight a couple things I thought were specifically important and might not have been addressed as much throughout today. In general, I'm opposed to physician aid in dying or physician assisted suicide, depending on the term that you tend to use. But specifically, I would like to address some of the issues regarding safeguards and my disappointment that we haven't been able to focus really on our philosophical differences and the actual issue regarding what a doctor's role is and the actual ability of individuals to choose to end their life, as opposed to having all these discussions regarding safeguards and things and issues that we've seen through the last 7 or 8 years every time this has been proposed. And it seems like very little has been done to try to alleviate anyone's concerns. And I wanted to mention earlier today, we heard testimony from Dr. Deborah Pasick. She submitted written testimony, and page 2, paragraph 2 of that testimony, she talks about 27 of her patients being prescribed lethal medication. She's a doctor in New Jersey, and only 14 have taken the dose. And while it's a great thing that some people chose not to use this medication, what this means is that there are 13 lethal doses of medication out there unregulated. We have no knowledge as to whether or not it will be used when they are still competent to make that decision. We don't know what's happened with it. People talk about there being no documentation of abuse, but it's because there's no regulation. We need to find ways to make sure that when we're dealing with a literal life and death scenario, people say that as an exaggeration a lot, but this is literal life and death legislation. We need to make sure that safeguards are in place. And along the lines of dealing with safeguards, I find it disappointing that it feels like this bill has been thrown together haphazardly. I join in the concerns from the Division of Criminal Justice. There was a whole section thrown in defining murder as someone is guilty of murder if they fabricate a letter requesting medical aid in dying. But there's no requirement in it that that individual die. Someone just threw this together and didn't think about how criminal statutes are applied. When we're dealing with life and death scenarios and serious things, we need to go through these things with a fine-tooth comb and make sure everything is accurate. We can't just say, well, it's good enough, it's close, we know what people are trying to do. If that's not enough, when things are applied in court, technicalities matter, wording matters. And the final thing I'd like to say is, on a personal level, as to the philosophy regarding choosing to end one's life. While I understand that we're specifically dealing with individuals who have been diagnosed with 6 months to live, the logic remains the same for other people with pain. There is a strong argument to be made that it is a much more painful existence for someone who's dealing with mental illness and psychological illness, who knows it's not going to kill them, but they have to live with this for another 60 or 80 years. What are we telling them? Are we saying that your life is not worth living because of difficulty and because of pain? About a week before Christmas, I had a friend call me, freaking out because he had been diagnosed with a mental illness, freaking out that his brain was broken, not knowing how he was going to go forward, what the purpose of his life was. I had to sit on the phone with him for an hour and check back in with him over the next couple of weeks. And I had to remind him that things are difficult, but there is value inherently in your life and the people who love you and that you love people. That's what matters most. And so I asked that this committee not create a system where the logic will apply to others. Life is always precious. Life is always valuable. It's not just about the quality. It's not just about the years, and it is quality of life matters, but we can add a quality to life in whatever stage it is. You can find a way to find quality in your own life. You don't have to find a way to end your life. Thank you for your time and for listening to me. And I hope you all have a good night. Thank you for spending all day with us.
Thank you so much for spending all day with us and for taking time to testify tonight. We really appreciate it. I don't see any questions, so thank you so much. Next is Sharon Hines, followed by Larry Rozzolo. Sharon, go right ahead. You're on mute. Sharon, you're on mute.
We go.
There you go. We can hear you, but we can't see you, which is fine. I just want you to know.
Okay, I'm not
Go
sure
right
why
ahead.
that is. Members of the committee, thank you for the opportunity to testify in support of HB 6425. My name is Sharon Hines, and this could not be more personal for me. I have stage 4 lung cancer. As a former hospice nurse and oncology nurse practitioner for many years, and as I testified before this committee 2 years ago, I've long been a supporter of Aid in Dying. Learning today that the Connecticut Nurses Association has submitted written testimony in support of this bill is such a big deal and a step in the right direction. I've learned through my own personal experiences of caring for family members who have died, as well as through many years of caring for patients with terminal illness, that not every death has a peaceful ending despite the best end-of-life care. What you need to know about me is I am not giving up and I am not depressed. I am by nature positive and hopeful. I am hopeful for a continued response to treatment, hopeful for a good quality of life, and hopeful for a peaceful death. What gives me hope for a peaceful death is knowing that if needed, I would have access to Aid in Dying. For that reason, my husband and I, both lifelong residents of Connecticut, made the decision to relocate to a state where terminally ill patients do have access to Aid in Dying. But how ludicrous is it that we have to uproot our entire world and leave family and friends, the people we need most at such a vulnerable time? We knew we would have to sell our home, the one we built 23 years ago with a plan to age in place, because it was not feasible to financially support 2 homes. Our house sold in 3 months, but because my husband is still working, we found temporary housing here in Connecticut. And our hope is to continue to live here as long as possible and until such time that I have exhausted all acceptable treatment options. It took several trips out of state to take care of financial and legal issues in order to establish residency. We found a place to live with my very best friend from nursing school that will be available whenever I need it. I had to find an oncologist and schedule an appointment to meet with him. All that I've done to ensure that I have access to Aid in Dying has taken a great deal of planning, research, and expense. I'm fortunate that I have had time, energy, and resources, but for many, they do not. Nor should they have to. It's time. All end-of-care life options are available right here in Connecticut. Lastly, I'm no longer preoccupied with dying from lung cancer. That not only takes your breath away, but in the case of cancer that is spread to your brain, your mind too. In fact, I really think about it now. There is no amount of therapy or medication that provides the peace of mind that I now have in knowing I will have access to Aid in Dying if needed. Thank you. I'm glad to take questions.
Thank you very much for your testimony. I'm sorry to hear what you're going through. Senator Wong.
Thank you, Madam Chair. And Sharon, even though we can't see you, I was really glad to hear your testimony, because I actually saw your testimony 2 years ago with Jim Naughton. And I know Jim mentioned your name earlier today. And I just wanted to acknowledge that I'm so glad that you continue the fight, and that just listening to you and your tone of positives is reassuring. So I just simply wanted to acknowledge your contributions to this debate, and really glad to hear your voice today. And you keep on fighting.
Thank you.
That'll be all. Thank you, Madam Chair.
Thank you.
Thank you, Senator. I don't see any other questions this time. Thank you so much for sharing your story. I wish you all the best, and I really appreciate you taking the time to advocate for this bill.
Thank you.
Next is Larry Rizzolo, followed by Diana Barnard.
Hi, can you see and hear me?
I can. Go right ahead.
Wonderful. I want to thank you for the opportunity to testify, especially 14 hours after you began. I greatly appreciate your stamina. My name is Larry Rislow, a professor at the Yale School of Medicine, and I helped design the curriculum for end-of-life care. My remarks are my own. I do not represent Yale. Let me first say I am your poster child for palliative care. But my message today is that this legislation offers patients the hope that they can live their remaining days. This may seem counterintuitive, so let me revisit patient-centered care, patient-centered medicine, and palliative care. Patient-centered care treats patients according to their cultural, moral, and religious values, not those of the clinician. The patient always comes first. Palliative care is all about giving patients hope. Hope that they might live their remaining days in relative comfort, enjoy time with family and friends, hope for so many things. Palliative care strives to give patients autonomy so that they can direct their care. We've discussed ameliorating the excruciating emotional and physical pain that distorts decision-making. And we've discussed compassionately discussing all the available options. But in the end, clinicians must respect the wishes of the patient, regardless of the clinician's values. The valiant efforts of palliative care are limited by the ugly nature of many diseases. HB 6425 offers patients, some patients, further hope that enables them to live their lives. In states with such laws, people often die a natural death because restoring autonomy and control relieved debilitating anxiety. Restored autonomy is the gift of life. This is no different than patients who refuse painful last-ditch therapies in order to live with their family and friends. Consider my friends Bill and Mary. Not their real names because what they did is illegal. Bill suffered from ALS, death by 100 cuts that leads to an inability to swallow. All the while, your mind remains sharp. Bill wanted to live until just the time before he can no longer swallow, i.e., lose autonomy, unable to take the pill that would allow him to pass with dignity. Make a long story short, once Bill obtained the means to do this, his immediate reaction was to go and to tend his neglected garden. In other words, help things grow, an affirmation of life. His personality was restored. Mary said she got her husband back. They lived joyously up until the end. Why deny people life? Because you're entering the domain of the doctor-patient relationship, I respectfully ask that you follow the principle of patient-centered medicine. Put the patient first by setting your moral and religious values to the side. Grant patients the respect, the autonomy to make this most intimate decision. Please enact HB 6425. Thank you, and I'm happy to answer questions.
Thank you very much for your testimony. Representative Parker.
Hey, Larry, it's John Michael. Thank you so much
Hey.
for being here with us tonight and for sharing. We appreciate you.
Thank you for staying up.
I was just wondering if you could speak a little bit about, you mentioned designing curriculum, and can you talk about how aid in dying or the lack thereof plays into your teaching of this broader field to students and sort of what you see from the landscape about the what our new physicians and providers are learning?
Yeah, so this all started some 20 years ago, about the time of Jack Kevorkian was gaining notoriety for helping people die. And he's a pathologist. He had no training in the end-of-life care. And so medical schools across the country, certainly at Yale, were kind of shocked and asked, well, where do we teach any of this end-of-life care? And scattered here and there were elements of it. So a committee was formed to develop this curriculum. I teach anatomy, and anatomy is the first time for many of these students to see a dead person, let alone touch them, and begin to dissect them. So we thought this was a good time to start the curriculum. So we made this 4-year integrated curriculum. Any opportunity that we could raise this topic to acculturate students to this issue. One of the things of medical education historically is to beat empathy out of the students. They enter compassionate people, but the nature of the training is counterproductive in that way. And so we felt it was very important, even in the anatomy lab, right outside the anatomy lab, through big glass pane windows, you can see what's essentially an art gallery created by students themselves and their reaction to the act of dissecting human body. And as we go through their education, you have to learn about so many things, medications for pain control, these kinds of things, but you also have to learn about cultural differences from people. Patient-centered care is about it's a holistic discipline. You have to learn about their families, and you have to learn about their religious thoughts, and you have to incorporate all of these elements into their end-of-life care. So it's a curriculum that extends the 4 years. Early on, we had someone who actually wrote a book, a surgeon at Yale wrote a book about assisted death. And he came to a few of our meetings, and we thought we didn't want to go there. First of all, because of the law, and second of all, because we wanted to have a program dedicated to helping people live the end of their lives and not necessarily giving them the means. My story of my two friends, they had to work in the shadows, right? They brought this up to their physicians, two of them, and they said, look, we can't talk about this. And so their doctors essentially abandoned them. And they had to go into the back alley, so to speak, to get the means to do what they hoped to do. Wouldn't it have been better if they had the peace of mind knowing that as the time got close, they could have this discussion? Wouldn't it have been better if they could have this discussion with their clinicians and palliative care team and help them make the most informed decision that they could? But no, they had to go into the back alley. And I'm hoping that with this legislation, we can stop that. So maybe that danced around.
Yeah, thank
your
you. I
question,
appreciate
but
that.
Yeah.
And Larry, I would just ask also, if you care to share more, you mentioned earlier, I think the word you used was, the phrase was the poster child for palliative care. Do you want to tell us about what, in your personal life and with friends or otherwise, and how your experience has maybe changed your position on this issue over time, or your understanding of it?
Well, as I said, I'm an anatomist, a biomedical researcher, but I learned so much working with this committee of physicians, hospice physicians, palliative care physicians, people that worked on the front lines of dying patients. And that has made me so much more helpful for my friends. My friend who had a brain tumor that eventually lost all his loss of his lower body, and he couldn't talk, but you knew he was paying attention, because when you spoke to him, he turned his eyes and he looked straight at you. And what do you do in that situation? I last saw him, he was waiting, he and his wife were waiting for the doctor to come and to essentially terminate his life in the way that the speaker 2 or 3 people ago. I had the chance to look into his eye and tell him what a good friend he was, and how he had meant so much to me and the men's group that we both belonged to. But then the most important, very important thing of that is, his wife said, well, I want to be alone with my husband for the rest of this time. I went into the waiting room where his whole family was, and we can sit and talk about Leroy and his life. And we could get them to tell all kinds of stories. And to his daughters, I said, he always spoke of you as little girls, and he was so fond of you. And it just got so many stories going. My cousin died of ALS, and working with him, his mother eventually died of stage 4 cancer. I'm thinking of my friend Kathy, who couldn't speak for herself in the last 2 weeks of her life, and sitting with her husband and helping sort through palliative care and different treatment options, and kind of mediating with the physician and the palliative care team. I mean, all of this I couldn't have done if I hadn't been working on this curriculum. And it makes me wonder, what do other people do that don't have the insights that I gained by doing this work? So I'm a huge fan of palliative care. I'm a huge fan of hospice care. But as other speakers have pointed out, it doesn't always work. And there have to be other kinds of opportunities. I've heard that, this is very rare, but, for Mary, it was 100% of her husbands found himself in this situation. So I don't care how rare this is, palliative care will do great for a lot of people, but there are enough people where this is necessary.
Thank you. Thank you for sharing.
You're welcome.
Thank you, Representative. Thank you so much for your testimony, Mr. Rizzolo. And I want to say too that you remind me of the fact that these things aren't mutually exclusive. That people can take advantage. In fact, I think that one of the statistics I read was that about 85% of people who choose aid in dying are also in hospice care. So so it doesn't have to be one or the other. It should be the best care that anyone can get.
It's not either or, it's both and.
Exactly. Thank you so much for being with us so late tonight.
Thank you. You're welcome.
Next, we have Amy Ewing, followed by Elaine Cole. Amy, go right ahead.
Yes, hello, everybody. Thank you to the Public Health Committee for drafting this bill carefully, and I am here in strong support of it. I know from my father's experience that sadly modern medicine has limits in its ability to relieve suffering at the end of life, even with palliative care. I submitted a written statement, so I'll be brief. My dad had a very aggressive cancer that was diagnosed, and he died within 3 weeks. It was that aggressive. He told his doctors that he didn't fear death, but he feared excruciating pain. And actually, he had fought in World War II. And he told everyone who came into the hospital room before he came to home hospice, that he felt that he was one lucky soldier because he'd had such a good life. But he feared excruciating pain, and his cancer had metastasized to his spine, and bone cancer is very, very painful. And of course, home hospice, his wife, my mom, had hired round the clock nurses' aides so they could keep an eye on him for whenever to try to stay ahead of the pain with morphine. And they tried to stay ahead, but they couldn't. He kept having what they call breakthrough pain, where it came much sooner than the medicine should have protected him. And I actually brought a prop to this this testimony. This is what a hospice nurse's aide has as a tool when there's breakthrough pain. You've given the morphine and it still hasn't kicked in. And what they do is they comb the scalp and just that very gentle motion gives the patient another sensation to feel, to try to distract them from the pain that's racking their body. And it was heartbreaking to watch him endure the pain, and heartbreaking to see how short a time this little distraction worked. So I ask you to please support Bill HB 624. It's the compassionate thing to do for terminally ill patients, especially those for whom their only future is severe pain that cannot be relieved. I thank you.
Thank you. Thank you so much, Ms. Ewing. Thank you so much for being here so late and for taking the time to share the story with us. Everyone we hear is so meaningful. So thank you for taking the time.
Thank you.
Next, we have Elaine Cole, followed by Tracy Wodash. Elaine, go right ahead.
I'm here.
There you are. Go right ahead.
I am. This is Elaine Kolb. I have passionately opposed Euthanasia Society. I'm so sad that they have used compassion when what real compassion is not what they're talking about, in my opinion. I am a person with a disability, with multiple disabilities, and I have been opposing this for most of my life. I was literally stabbed in the back 43 years ago. I have an incomplete spinal cord injury, and I know from personal experience how people with sudden, traumatic, dramatic disabilities sometimes want suicide. And you know what? One of the things that happens is that if people are not provided with opportunities to live in freedom in the community, then they want the suicide. So please do not pass this. This is a whole thing. If you want to know what it's really about, go back and study the Hemlock Society. They changed their name, but they're doing the same things now. This is not what you think it is. Euthanasia is what they want. Read their stuff. They have repackaged it into something that looks really nice now, but it's not. And I am severely insulted by the kinds of comments that are made about people with disabilities, that we are not sophisticated enough to understand what these things are really about. Most of you don't understand, as non-disabled people, is that there are public health issues relating to ableism and disabiliphobia. That's the fear of disability. And I'm dignified with my disability. My disability doesn't make me to live an undignified life, and yet some of your people would say they would rather be dead than to be like me. And some people like you have said that to me and my friends. I have been the primary caregiver for a partner who was dying. I have been involved with hospice multiple times. I have assisted people to move from one state to another because they couldn't get the home care they needed. So as a public health committee, please focus on providing real health care for everyone, and not just for relatively privileged people who want to have this choice, this
You hit your
control.
3-minute mark, if you wouldn't mind concluding your remarks.
I'm just saying, I'm begging you. There are no organizations of people with disabilities that support this. There are individual people, yes, But why is it there are no organizations of people with disabilities that support it? Because we know that this is the ultimate discrimination. It's deadly and it's killing our people, and there's so much abuse against people with disabilities. It's shameful.
Thank you very much for your testimony and for being with us so late tonight. And I appreciate your passion and your willingness to stay with us so late and share your perspective. Thank you.
I had oral surgery yesterday. I would have taken my Tylenol and codeine and gone to bed. But I am here because of the fact that so many of my people special to me want me to speak about this, and I have.
Well, we appreciate you doing that. And I hope that you can take your medications now and get a good night's sleep, because you certainly are a strong advocate for your community. Thank you. Next, we have Tracy Wodash, followed by Robert Hale.
Thank you. Senator Abrams, Representative Steinberg, members of the Public Health Committee. Thank you so much for sticking around all day and all night. My name is Tracy Wodash, President and CEO of the Connecticut Association for Healthcare at Home. I'm also an RN with nearly 40 years experience in home health, hospice, long-term, and acute care. The Connecticut Association for Healthcare at Home is the united voice for the hospice providers in Connecticut. We once again polled our hospice provider agencies about aid in dying, receiving mixed responses of opposition, neutrality, and some in support. Regardless of stance, one message remains unanimous, and that our association and its hospice providers are committed to the hospice philosophy, cherishing life until its natural end, while reinforcing dignity, quality, and comfort for both the patient and their loved ones. I'm not here to support or oppose HB 6425. Rather, I'd like to spend my time addressing some of the comments from today. Senator Summers asked about hospice and palliative care in Connecticut and reasons for limited advanced care planning conversations. The data shows that Connecticut remains second to last in the country in median hospice length of stay. This translates into last-minute hospice referrals. We treat and treat, yet don't recognize when patients no longer want to be treated. We fail to have timely goals of care conversations and referrals to hospice. We do truly struggle in having quality conversations about death and dying in Connecticut. Initiatives to improve serious illness care in Connecticut are underway, but in no means well developed. MOLST was mentioned earlier. Connecticut has a mediocre MOLST initiative, which, if completed, helps capture an individual's personal goals of care. In the midst of the pandemic in late 2020, we created a statewide coalition for serious illness care, which is just beginning to work on advanced care planning, legislation, and advocacy. All initiatives that need further development to enhance informed decision-making regarding end-of-life care. Regarding my written testimony on file, the following highlights are suggested edits to the bill. Stronger pharmacy protections, including a way to ensure proper and safe disposal of any unused medications. Clarifying the difference between palliative care, which should be offered across the span of serious illness, and hospice care, which is palliative care, but reserved for those with terminal illness and a prognosis of 6 months or less. In the current bill, the term hospice is used just once. Yet tonight we've mentioned it perhaps 100 to 200 times. Please define hospice in this bill. We've referenced Oregon's data multiple times tonight. This bill must include a clearly outlined process for annual data collection to capture any trends. We also need a work group similar to California to establish strong policy and education, and one that Caroline Boas would be happy to participate. Finally, we urge bill language that includes a simultaneous referral to hospice if hospice is not already in place. The association and its members fully support the hospice philosophy and care at end of life. Thank you.
Thank you very much for your testimony. Representative Steinberg.
Thank you, Madam Chair. And Tracy, thank you for sticking with us to the near the bitter end here.
Yeah.
And thank you for everything that you and everybody in your organization does. You're absolutely right. We spent a lot of time talking about hospice, which I think we probably all think is a good thing, and understanding it better and putting it into context. As for not having a definition in this particular bill, I'd like to believe the reason we don't is that it's defined elsewhere in statute, but we will definitely look into that. And if you have any other suggestions that will create the right context for considering it and dying this bill, we would greatly appreciate it. Thank you, Tracy.
Thank you, Representative Steinberg. I would say that actually the language, the definition of palliative care within the bill actually closely defines hospice. So I think we really need to look at trying to clarify both. Palliative care is not for terminal illness. Hospice, which is a form of palliative care, is. Palliative care is supposed to be given throughout serious illness, from the start of the diagnosis through. So I think it's important to make sure that's clear in the language, because right now it almost is defined as hospice care.
Well, we've learned a lot about those differences, and maybe you can help us get it right as we make refinements to the bill. Thank you, Madam
Would be
Chair.
happy to. Thank you.
Thank you. Representative Pettit.
Thank you, Madam Chair. Thank you, Tracy. The lack of utilization of hospice and palliative care remains puzzling, given the fact that we tend to have an older than average population, older than average physicians, but fairly sophisticated population overall. Other than education, do you see any straightforward ways to try to increase the penetration in the market and get more people involved at an earlier stage?
Well, I think we've seen a lot of discussion tonight. We've heard a lot of discussion today, and I think we do have some racial inequities that feed late referrals or no referrals to hospice. And that's an area that we really should work diligently on in Connecticut. I also see us as the sandwich state between Boston and New York. Connecticut also has extremely highly skilled physicians and practices and treatments. People tend to want to get the experimental treatments and continue to treat and treat. So it ends up that hospice is a last resort, when really hospice shouldn't be a last resort. It should be an option that is discussed very early on in someone's serious illness. So I would say continued education, yes, but practice. I think what Mr. Rizzolo said regarding the palliative care training at Yale, we need to do that throughout all of our medical schools, as well as all of our nursing and social work schools.
Thank you. Thank you, Madam Chair.
Thank you, Representative Claire DeStitria.
Thank you, Madam Chair. Thank you, Tracy, for being here so late with us tonight. I'm sure there's no other place you'd rather be. Can you explain to me how, when someone goes into hospice, how they differentiate between going into the hospital for hospice or home care for hospice?
Yeah, I'm really glad you asked that question, because I heard your question earlier to, I think it was Kristen, why her mom hadn't gone into the hospital for hospice care. Hospice is a philosophy of care. It's not a location of care. We go to wherever the person is. So if the person is at home and they want to stay at home, we bring hospice to them. If they are a resident in a nursing home or an assisted living, we bring the hospice team to them. In the hospital, there's only, according to Medicare, there's only one level of care that can be given in the hospital, and that's an inpatient level of care, which is someone that is in highly unstable status. Their symptoms cannot be controlled without constant evaluation, skilled assessment, the physician right there with the nurse, and making constant changes to the plan of care. So it's considered like crisis care when you're actually staying in the hospital in a hospice inpatient level of care.
And that makes sense. My father, who passed away in October, was in the hospital for his hospice care. But with the woman who I asked the question to why she was home, and is that the normal care that they have, the family making all those decisions and deciding which drugs to give and to figure out when they're in pain. It just seems like for a lay person, that's a very tough decision to do. And I think she said a nurse only came in once a day. It just doesn't seem like that's reasonable care for people in hospice.
Yeah, that would be routine level of care. There's 4 different levels of care for hospice, and the nurse would go out, and it could be once a day, it could be every other day, whatever the plan of care is based on the assessment by the hospice team, in conjunction with the physician. But what they do is they evaluate the home situation, and they do a lot of training with the family. It is, you want your family to care for them at home, and you want them to understand it is a lot of pressure to have them at home. But at the same time, if the family wants them there, then the nurse needs to do all that she can or he can to train them on how to care for their mom.
Thank you. And my last question, and when they're administering, they're giving them meds, could they be oral or could they be by injection? Do they do?
Yeah, the most common treatment for pain management at this point is, as Kristen had mentioned, I had to give her something in her mouth. It's just a highly concentrated dose, usually of morphine, that you just do as a dropper. So it's less discomfort of an injection. There's no need for an IV.
Right. But is it ever an injection?
Adds fluid.
Is it ever an injection, like a single syringe injection? Do they ever do that or no?
They do, but it's not as common nowadays. There's much more comfortable ways to provide the pain management.
Right, because it's so easy to do an injection if they had to, right?
It is. If they had to, it is. But that the under the tongue, highly concentrated morphine works very well.
Right. Okay. Thank you so much for your testimony. Thank you, Madam Chair.
Thank you.
Thank you, Representative. Thank you, Tracy. I think that's all the questions that we have for you tonight. I just want to thank you for all you do in your professional work and all you do for us up at the Capitol and working with us and helping us understand things better. So thank you so much for being here. So
thank you to the entire committee and Senator Abrams for your comments.
You're muted,
Sorry.
Mary.
Next we have Jeffrey Gardier, followed by Thomas Finn. Jeffrey, there you go. Go right ahead.
Yes, ma'am. Thank you so very much. All I can say is thank goodness for Bustelo coffee. Thank you all for being here, staying so late. Really, thank you, thank you, thank you. Good evening, Chair Steinberg, Abrams, Vice Chairs, Ranking Members, and members of the Joint Public Health Committee. As you know, I'm Dr. Jeff Gardier. I'm a board-certified clinical psychologist and ordained minister, a professor at a New York Medical School where I teach students behavioral medicine, cultural sensitivity, cultural competence, health disparities, and the sanctity and quality of their patients' lives. While some who oppose this legislation and believe that people will be pressured to end their lives, this belief is not supported by the data. We know from more than 20 years of experience in Oregon, as we've heard over and over again, the nation's first medical aid in dying law was implemented, and the experience of other authorized jurisdictions have told us that there has not been one single instance of abuse or coercion, and the legislation proposed here in Connecticut contains more than a dozen safeguards. Dan Diaz talked about this at length. I'll talk about it very briefly, given the hour that we're in right now. Though I understand the concerns of the opposition to this bill, scientifically and factually, it's incorrect to equate terminally ill adults who want the end-of-life care option of medical aid in dying with people who are suicidal and unfortunately attempt or are successful in taking their lives prematurely. According to the American Psychological Association, they are fundamentally different. The American Association of Suicidology also argues medically and legally, physician aid in dying and suicide are conceptually different. In suicide, a life that could have continued indefinitely is cut short. In medical aid in dying, death is foreseeable and in some cases imminent. Most people who take their life prematurely have the choice to live, but under the influence of psychological illnesses, choose not to. Terminal patients who may use medical aid in dying are legally competent. They do not have the option to live. The illness has taken that decision away from them. The question then becomes how they die, not if they will die. I have talked to and counseled countless people, and none of them want to die, but they know that one day this will be their fate. And for the terminally ill, it will come sooner rather than later. Many who have lived life with courage and spirit are less afraid of the end arriving and more concerned with what the end of their lives will look and feel like. They seek a respectable quality of life, peace, comfort, and most importantly, dignity. Medical aid in dying provides that, but ensuring patient autonomy, a key component of adulthood. Medical aid in dying is not the right end-of-life care option for everyone who would qualify.
The 3-minute mark, if you wouldn't mind concluding.
Yes, I'm on my last point. It should be an option, a legal right available to all. Now, for those who may say that because of the pandemic crisis of COVID-19 and the tragedy of over 500,000 souls lost in the US alone, that now is not the time to discuss medical aid in dying. But it truly is, because as we know, that even though medical aid in dying may not have been helpful to these COVID patients because of the rapid progression of their symptoms, the point is that many of these patients died in a hospital, isolated from their loved ones. And to close, this is perhaps the kind of death we fear the most, and a stark reminder that as a society, we should not be lulled into the fallacy or the false sense of security that the end of life period comes only to those in old age or who've been chronically ill. Today, we've learned that anyone, you and I, young and old, our friends and family, sick or healthy, can become terminally ill at any time in our lives. And I know that as elected officials, some of you are on board for this bill, and I thank you. And there are others who are thoughtfully and intelligently still wrestling with medical aid in dying, and I respect that fully. But please consider, there are too many ill, dying people in Connecticut who are and will be unnecessarily suffering at the end of life. There are too many ill adults who passed away advocating for passage of this law. And finally, they are clear as to wanting autonomy, making their own decisions at the end of life. We owe it to all of them to provide this end of life care option.
Doctor, I need
Please
to
pass
stop you.
this bill now. Thank
Doctor,
you.
I'm sorry, your time is up.
Thank you.
But I have to say how much I appreciate your positive energy
Thank
at this
you.
point in the evening. So
Thank you.
It's really refreshing, and thank you so much for your
And thank you,
testimony
and
tonight.
thank you for allowing me to finish. Thank you so very much.
Have a good night.
Thank you.
Next, we have number 118, Thomas Finn, followed by 119, Robert Russo. Mr. Finn, go right ahead.
Good evening, Chairperson Abrams, Chairperson Steinberg, and members of the Public Health Committee. My name is Dr. Thomas Finn. I am a resident of Southington, where I have worked as a Connecticut licensed psychologist in private clinical practice for over 35 years. I'm writing to ask you to oppose Bill HB 6425. And certainly we've heard the stories of everyone's struggle today, and it's stories I'm very familiar with, both professionally and personally. But still, I do not believe, in the midst of the kind of suffering we all experience with this, that the bill and its concepts will benefit our citizens here in Connecticut. My primary objection to the bill centers on determining who qualifies as a subject of the bill. As the bill says, qualifications will include patients who voluntarily seek their deaths and competently make informed decisions regarding the nature, consequences, benefits, and disadvantages of their choice to end their lives. I share the opinion of many healthcare providers that it is extremely difficult to determine really who can be defined as a qualified patient. The desire to hasten one's death has been associated with higher levels of psychological distress and depression in terminally ill patients, which impairs the ability to make a truly informed decision. Suicidal ideation and behavior are recognized as symptoms of major depressive disorder, and a person's capacity to competently assess his or her medical situation can be distorted by that depressive cognitive state. Professionally, we talk about a negative triad that reflects depressive views of oneself, one's present circumstances, and one's future. And those cognitive distortions are related to increased feelings of helplessness, guilt, and worthlessness, resulting in misperceptions that life is meaningless. The hopelessness experienced in the hearts of these patients distorts their understanding of objective information about the quality of their remaining days, the number of which are often underestimated in their medical prognoses. It can also limit their ability to perceive benefit from palliative treatment. Given the frequency of depressive symptoms in patients who are terminally ill, the frequency with which depressive symptoms are not diagnosed by general practitioners, and especially the historically low rate of psychiatric evaluations performed with persons seeking physician-assisted suicide in states such as Oregon, patients are at risk of being mislabeled as qualified or competent in making informed decisions, in fact, when they are not. I think personally to be compassionate means to suffer with a person who's in need, and to suffer means to bear the burdens that one carries. And I hope that we can view a person who is terminally ill and their desire to die as a request for help in bearing the grief that they're experiencing, and to work to improve our ability as a community.
You hit your 3-minute mark, if you wouldn't mind concluding.
Last sentence. But improve our ability as a community to compassionately provide terminally ill patients and their families with services that target effective pain management, along with the emotional and social support that they need. So I thank you very much for your time and the length of your stamina.
Thank you, Dr. Finn. There's some questions for you. Representative Pettit.
Dr. Finn, thank you very much for sticking it out with us all day. So your objection to this bill is really based on the appropriate identification of appropriate patients versus some disagreement with how appropriate it is for caretakers to provide this kind of therapy for people. Is that correct?
Therapy meaning end of life medication. But no, I think I have a number of issues. I wanted to speak primarily, given my role as a psychologist, to just the concern of that I have with the concept of being an informed patient or someone who's competent. The reality of making competency decisions, I believe, and it's not my area of expertise, but I believe that there are a lot of legal components in that. And I know that in my own experience, I've had a number of relatives go through the process of hospice care, and when they were initially diagnosed as terminally ill, I think of my mother in particular about 10 years ago, who, when she was talking with her physician who explained her cancer situation and what she was looking at, I remember I was there with her in the office, and the doctor said to her, "So Mary, do you understand everything that I'm explaining to you?" And she said, "Yes," very clearly. When we got in the car, she turned to me and she said, "What exactly was he telling me?" And I said, "Well, did you not remember or understand what he was saying? Because you said, yes, you did understand it. And she said, I just didn't want to look silly. But she did not understand it. So that's really where a lot of my worries are, because she knew she was very sick. She had a sense that things were going to be very difficult in the road ahead. And I think her judgment, or the emotion that she was experiencing, was so intense that it really didn't let any of that information sink in. And she was not someone experiencing dementia at that point. So I think my concerns are just really focused on that in terms of the testimony I wanted to provide.
Thank you, Doctor. Thank you, Madam Chair.
Thank you, Representative. Thank you again, Dr. Finn, for being with us so late tonight and for providing your testimony. Appreciate it. Next, we have number 119, Dr. Russo, and followed by number 121, Lydia Bennett. Dr. Russo, go right ahead.
Good evening, Senator Abrams and Representative Steinberg and all the weary members of the Public Health Committee. It's like being on call as an intern. I've never seen people stay up this late and pay that much attention. Some of you recognize me as the Executive Director of the State Medical Society, or a past president. The position of the State Medical Society, to be transparent, is what's called engaged neutrality. I know the word neutrality makes it sound kind of wishy-washy, but the truth is there's 4,000 members in the state society, and there's numbers on both sides, some of which you've heard from tonight. What I want to get into, though, rather quickly in the 3 minutes is good news. Where we have progressed since having testified 5 times or whatever on this death and dying issue, we're doing very well, and I haven't heard it. We have in Connecticut now paid family leave. That paid family leave now means that families can be home with a loved one during these events. I think that's a tremendous advantage over many of the other states. That's one issue. The second big issue is we're developing an HIE system in the state of Connecticut. I do have a little trouble with the bill, and overall I am opposed to the bill. But what bothers me about the bill itself is changing the death certificates. As you know, with the health information system and artificial intelligence, we're now able to gather data out of the medical records and out of the patient treatment patterns that allow us to then predict. And I know there's a difference, and I truly believe there is a difference between the suicide that you talked about in a different forum about preventing suicide versus this aid in dying sort of bill. But if you look at the work being done at UConn for suicide prevention, especially Rob Azeltine's work, you can actually predict who is going to be more liable to have suicide tendencies. Therefore, in this bill, if you remove that from the death certificate, you remove it from our ability to database that sort of thing, I really think you're making a mistake. And I think one of the earlier people today had said, I think it was Mr. Diaz, they don't really care, the proponents, if it says, died of lung cancer with death and dying as an aid. That doesn't bother me either. The bill bothers me, but that doesn't bother me. I mean, I think those are kind of important things. The other thing I wanted to do quickly is, it's come up many times about the difference between palliative care and aid in dying. And I think you really need to understand, and I think Dr. Pettit mentioned it, and one of the earlier ones did it, it's the intention behind what we're talking about. The real question is, the aid in dying issues come up 6 months before the event. If you've noticed in conversation, hospice has pointed out multiple times that they never get that 6-month advantage. They get the advantage in the last month or 6 weeks of somebody dying. So when you're talking about aid in dying and the reasoning behind it, that's where the Oregon information comes out, that it's based on, I don't want to be a burden. I don't want to be a financial burden.
You hit your 3-minute mark. If you wouldn't mind concluding your remarks.
That's almost impossible in my life in 3 minutes. But the reality of it is that there's so much more to this complex issue. I mean, we might be a little early in the process, but it is a process. We have paid family leave, we have better hospice, we have better tools in the toolbox. We can do a lot more before we have to get to the point where we have to pick and choose who might have to cause death.
Thank you, Dr. Russo.
Thank you.
Representative Pettit.
Thank you, Madam Chair. If you'll indulge me, I'd just like to make a comment on something Dr. Russo commented on and get his response, because this came up before with someone who testified on the CDC's position. And for the other people on the committee, I was looking earlier for what the state's chief attorney had testified. I couldn't find it, and for those of you looking for it, it's filed under T for the Division of Criminal Justice. So I looked under C and J and it wasn't there, but if you look under T, it's under the. And in their second paragraph, they say, 6425 effectively mandates the falsification of death certificates under certain circumstances. States the person signing the qualified patient's death certificate shall list the underlying terminal illness as the cause of death. This is simply not the case. The actual cause of death would be the medication taken by or given to the patient. And I think that's what Dr. Russo was referring to. And I don't know if Dr. Russo, if you have anything further to comment on that, but clearly the state's attorney.
Yes, no, there's no question about the source of the data has to be true. I mean, there's no way to go backwards and restudy what's been done. I mean, it's a simple principle about if you do something, you need to go back and review it to see if it was done right and what consequence it's going to have further down the line. I mean, it's the same concept of the double effect that everybody's been talking about in intention. But without that data, you can't do, I've heard many times today, people said that, well, there's been no incidents of abuse in Oregon. Well, there won't be any incidents of abuse if you don't have a system or a mechanism to count that as abuse. If it doesn't show correctly or there's no organization, there are doctors, by the way, that have been prosecuted in Oregon, and it's impossible for somebody to say there's absolutely never been levels of abuse, and we all know it. I don't think this is a hidden thing. My example in this, and it's tragic, and I spent the day with you all. It's a tough day to listen to some of the tragedies that have gone and been described today. But how does an ALS patient fit into the law? An ALS patient that's terminal can't swallow, definitely couldn't put a series of pills in their mouth, and definitively couldn't swallow 6 ounces. So the law doesn't really cover them. And there's a whole nother group, and actually I didn't hear it at all today, which is the Alzheimer's group. They don't fit into these definitions at all. But again, you're talking about chronically very ill people. The solution isn't in this death with dying or death with dignity and medication. The system is getting a process like hospice, beefing it up to the point where it's competent and can do its job. I mean, there was very little conversation, by the way, of going from hospice at home to a hospice facility to a hospice in a hospital. In my written testimony, I used the Journal of the American Medical Association to give you other points about what needs to be done to help. But we have other issues. We have health equity issues. Where is the money in Medicaid? Where is death and dying information in the Medicaid program? It's not paid for. So until you can do everything right, I don't think you get to this endpoint. It's just too early to be there.
Thank you.
Representative Foster.
It's like after midnight, so I apologize to everybody for doing this at the last minute. But an important point of clarity, Dr. Russo, if you don't mind helping me out here, I wasn't familiar with how the National Vital Statistics reported cause of death. And this has been a really big point of contention in reporting of COVID deaths. So I had looked it up related to the controversial news about COVID related to cause of death. And I wanted to make sure that I understood it correctly. And it is my understanding, and I'm like looking at this right now as we speak, that for every reported cause of death, you can report two parts. There are 4 lines that in the medical examiner's report you can report as immediate cause of death and underlying conditions. And then there is a part 2, also part of this report, that asks for other significant conditions contributing to death. And all of those points of data are part of the National Vital Statistics. So because this sounds like it's part of your criticism of the bill as it's currently written, is there a way that you would feel comfortable with the vital statistics being reported that would absolve that opposition?
Yeah, it's the same basis as I have with a lot of statistics. Until it's uniform and across all platforms, it's very difficult to mine the data electronically. You can do it easily by hand. But in death and dying, the way it's been described today, it is the #1 cause. If you give somebody medication that they die from, that is the cause. It's the major cause. It has to go on the top line. So the next problem is, what else is filled in? And there's no room for the mental health aspects. As a rule, you get death and dying. I don't want to say suicide because I understand that it's late, people get offended, but it's rare to see death and dying, lung cancer, depression, and things like that. And until we can mine that sort of data and use the artificial intelligence to pull all that data together so that we can find out where it's going to be and what effect it's going to have, it cripples being able to do the science. It's a very important point.
I understand that. So it is, are you presuming that it's your understanding that when we use algorithms to predict cause of death and predict things that would contribute to someone choosing an option, let's just presume that we're not talking about aid and dying, but suicide in general, that they're not looking at like the second and third items that might be listed there? Because I think statistics allows us to be more sophisticated than that. I think it allows us to look at if it's reported more than one line. And I don't think that this bill prohibits the other reporting.
No, I'm sorry. It doesn't forbid it, but I worked with Calvary Hospital in the Bronx for years. And one of the problems we had was that the second and third, and sometimes even the part 2 parts are not filled out correctly. And there's not a lot of direction into what part it should go. And what I'm worried about is that if you use this medication that will eventually kill the patient, that it's not going to show on the line. You're not going to be able to go back and do it because it's not considered, in quotes, an illness as it would be described on the death certificate.
Okay. The National Vital Statistics reporting documents do not specify that it needs to be an illness. It does say you can list sequentially conditions, if any, leading to cause of death, and it includes options for underlying, and it even allows specificity for immediate cause, intermediate cause, and underlying cause. But I'm not a doctor, a medical doctor. I'm a PhD doctor, so yeah. I don't. This is out of my scope, but I think that this is worth perhaps an offline conversation about to make sure that the language is right to allow the right data to be collected, because it sounds like people are uncomfortable with some of the nuance of the data, but good data is very important. So I agree.
Yes. If you read the law the way it's written, it says that the cause of death, the principal cause of death, is not to be the aid and dying issue. It's to be the other issues. It's not going to be the important piece for this sort of artificial intelligence to be able to go backwards, figure out where we need to go and how we need to do it. I think we're on the same page, but
yeah, I understand what you're
trying to read it into the law.
Yeah, I get it. Thank you.
Thank you very much for your testimony, for being with us so late, Dr. Russo. Appreciate it.
Thank you. Good luck.
Thank you. Next is number 121, Lydia Bennett, followed by number 122, Diane Keefe. Ms. Bennett, go right ahead.
All right, thank you. Members of the Public Health Committee, my name is Lydia Bennett, and I respectfully oppose HB 6425. I would like to respond to the idea we sometimes hear related to this issue. If you don't like it, you don't have to use it. The idea that if you don't like the concept of this bill and it's not going to affect you personally, it's not really your problem. But my concern is that this is not really about who will use it and who won't. It's about giving our assent in the first place. There is a big difference between choosing not to use something for yourself and giving your assent that it is acceptable. We're asking society as a whole, through the process of legislation, to approve something that up to now we have collectively agreed does more harm than good, choosing to end one's life. An illustration to help visualize this would be, imagine there is a toddler in his bedroom getting ready to jump off his bunk bed to the floor. You could say that if I don't want to jump off my bed, I don't have to. But if I'm in his bedroom, I have to either give approval or disapproval. I either have to say, don't do that, it's dangerous, or go ahead, have fun. Or if I watch without saying anything, I am giving silent assent. There is no neutral ground. And so it is with this issue. There is no neutral ground. Even for those who will never choose to end their life in this way, we are asking Connecticut to give its assent to a morality that is relative in its measurement, unsteady in its nature, and dangerous in its implications. For these reasons, I ask you to oppose HB 6425 and pursue solutions that strengthen and increase our ability to alleviate suffering without compromising our foundation. Thank you.
Thank you very much, Ms. Bennett, for your testimony tonight and for being up with us so late. We really appreciate it. Next is number 122, Diane Keefe, followed by 124, Joan Kavanaugh.
Hello, I don't know why my video isn't showing, but can you hear me?
We can, go right ahead.
Okay, thank you. I am in support of 6425. I did submit written testimony, but briefly, it was my favorite aunt who had suffered a stroke and could not speak, and she was suffering in a hospital. She was alone, a widow. No one was keeping track, and there are perverse incentives where sometimes if Medicaid is paying, people are kept alive and kept alive and kept alive. And I did visit her, and she was very small, basically starving to death in that hospital. I knew her. She was always vigorous, and she lived with dignity. And this was in a period of time in the 1980s, early 80s. So none of this discussion was happening in the public domain at that point. But I feel responsible as her loving relative that people similarly situated should be able to make choices when they're of sound mind and terminal, that they should be able to react and have some option to terminate their own life. And the other story, which is much more relevant, is of a friend who passed away about 5 years ago, who I had served with on a nonprofit school board. And she literally, while I was visiting her, while she was in home hospice, said, "Can you help me end my life?" And I definitely felt that it was somewhat depression and that she should be treated with antidepressants before she makes that final decision. And I asked her whether she had spoken to her husband about it, and she just waved it all off and just wanted me to really help her. So I know that there are so many people who would like to take their own choices into their own hands. And I think that the way this bill is structured and the way it's implemented in the states where it's already happening is to a great extent giving people to live out that notion of life, liberty, and the pursuit of happiness. And having the 15 days apart and 2 different times when you have to tell 2 different doctors that you want to make this and you're of sound mind when you make this decision, I think is adequate. And I think all of these other circumstances where they're saying there could be abuse of it, there are criminal cases in life and in medicine. And I think that there will be less harm by allowing this to move forward. And most of these people cannot speak for themselves, so I am speaking for the 2 people that I knew personally who would have benefited from it. Thank you.
Thank you so much for your testimony and for staying with us so late tonight. Really appreciate it.
No problem.
Next is 124, Joan Kavanaugh, followed by 125, PJ Schimmel.
Can you hear me?
We can, go right ahead.
Now I'm doing start video. I don't know if that's gonna, there we go.
Yes, you are on video now as well. Go right ahead.
I have submitted written testimony and I would refer you to that. In that testimony, I've testified every year against these bills. And I've provided at the end of that testimony all of the links to my previous testimony, and I'd appreciate it if people would read that. I have been a lifelong human rights and anti-war and anti-death penalty activist. And I'm also someone who has repeatedly witnessed and fought against attempts by the medical system to restrict and withhold healthcare. As such, I strongly oppose any bill to legalize the medical termination of a person's life for all of a patient's life for all of the reasons that have been described today. And in my testimony, as you'll read it, I'm trying to go as quickly as I can. I know it's late, but I've been here since 8 o'clock this morning too. There's no evidence that this practice is or can be adequately monitored to protect against coercion, abuse, or worse at any stage of the process. Moreover, such legislation can only serve to increase the disparities and prejudices in treatment access that have so dramatically been brought to public attention during the COVID crisis. And I have read the bill. I have it right here in front of me. I've marked it up. It's problematic in itself. I think those reasons have all been articulated. And I want to say it's problematic in itself, this bill, but any of these bills cannot be discussed in isolation, and that is the mistake that continually gets made. I saw an article in the New York Times of May 33, 2020. It was called "Who Lives, Who Dies? How COVID-19 Has Revealed the Deadly Realities of a Racially Polarized America." That article reported that "My life, my death, my choice," which, as we know, is the slogan of Compassion and Choices, found its way onto a sign at a Trump super spreader event, "You Can't Close America," last year. There's no surprise to me because the premise is the same. The premise is that individual decisions can be made in a vacuum and that they have no impact on the rest of the community. That's not true. That is simply not true. Under our current healthcare system, assumptions and judgments are repeatedly made about someone's quality of life based on a practitioner's personal preferences and prejudices. I've seen this, and I'm going to talk about it if I have enough time, about my own experience with my mother. The social Darwinist mentality is alive and well. And if anybody who's experienced this, and I, not only with my mother, but with other people, I have seen this happen. These prejudices that we have that are already in existence.
Sorry,
Gently mixed. I'm not finished. I'm sorry, but other people have gone further. I'm going to finish this, please. These prejudices form a deadly mix when combined with the cost-cutting agenda, which dominates the medical profession these days. And I saw this close up when I tried to get intervention and medical care for my mother at Yale New Haven Hospital. I described this in detail in my testimony, but I was browbeaten I was told under the guise of compassion for my mom, thin veneer, I was given pious phrases about death with dignity and quality of life. And I was also told point blank by these people, by hospital personnel, that she was costing them too much because she had a long hospitalization. That is the medical system that you are bringing this into now. That's unconscionable. That is unconscionable.
Thank you very much for your testimony today, Ms. Kavanaugh. Appreciate you being here so late with us. And Kavanaugh, I apologize.
Right, thank you.
And for spending the day also. Thank you so much. Next is PJ Schimmel, followed by James Turcos.
Yes, hello, my name is PJ Schimmel. I live in Norwalk. I'm a Connecticut native. On April 16th, 2017, my beloved wife, Morgan Zale, passed away. We had been together 36 years, and her death left a hole in my heart. She had been diagnosed with ovarian cancer in January 2010. In July of 2016, we were told that it had spread and she had 3 to 8 months to live. She was at peace with dying, even happy with the death sentence, because she suffered from several other conditions and her quality of life was low. She did not die of natural causes, however. She took her own life by VSED, voluntarily stopping eating and drinking. She chose this course because she thought it was the only way left for her. She had tried to OD in October on a mixture of drugs and alcohol. After one of the saddest nights in my life, I found her alive in the morning. I made her promise not to try any other methods that might leave her brain damaged but still alive. She would have loved to go to Vermont to take advantage of their right to die law, but her mental and physical condition ruled that out. Watching her die of VSED, first at home and then at hospice, was one of the hardest things I have done. She lasted for 23 days without water or food. Seeing someone shrivel up and die of thirst is inhumane, but it was her wish and I respected her decision, though it tortured me. She was a very strong-willed woman. I told everyone I met at hospice that I would be the first to testify when a right to die law came up in Connecticut. Morgan wanted that law badly. So this one's for you, honey. We treat animals in this country better at the end of their lives than we do humans. Please help change that by passing HB 6425. Thank you.
Thank you so much for your testimony, and I'm so sorry for your loss. Representative Claire DeStitria.
PJ, thank you so much for your testimony, and I too am sorry for your loss. How long was she in hospice for? I'm sorry if you said it.
She was on home care for almost a year, and we were in hospice together for 12 days in the building.
And did she stop eating when she was home?
Yes.
And then you went to hospice in the hospital?
She stopped the 23 days, half of it was at home, and then we had to move to the hospice building in Danbury.
Okay. Thank you so much for your testimony. And again, I'm very sorry for your loss.
Thank you.
Thank you, Madam Chair.
Thank you, Representative. I don't see any other questions. I just thank you so much for being with us at such a late hour and for sharing your story. Appreciate it. Next is 126, James Turcos. Mr. Turcos, go right ahead.
Hi, yeah, my name is James Turcos. I'm from Woodbridge. I'm glad to be able to testify today. I signed up for the February 16th hearing and didn't get a chance to speak along with many others. Everything about this remote session, it's tough. And in my opinion, though, it does erode the representative process under the guise of safety. And I get it. But I don't really like that the idea that profoundly life-altering legislation is being considered over Zoom under these circumstances. Perhaps the time could be better spent further researching and collecting comprehensive and long-term data on controversial bills like this one, so that next session or some other future session when proper public discourse and representation can be restored, we will have better written and more inclusive legislation to consider. And I know the discussion on HB 6425 does seem pretty mature. It's been around for years. It's comprehensive. It's pretty comprehensive from what I can tell in terms of dealing with most or all of the potential considerations surrounding the impact and the implementation. That's not necessarily the case for all legislation that's under consideration now. The subject matter of this bill is extremely important to a lot of people. And I have all respect for those who have testified in their stories. But I have to just, after listening to the hours of testimony and questioning today, it is interesting to me to see that many of the same representatives that based on the discussion seem to be supportive of this type of legislation in the interest of keeping choice in the hands of individuals to control their own lives and their medical decisions. Many of the same people are in favor of removing choice with regard to other issues, especially one particular one I have in mind, obviously. I would presume that this would be in large part because seeking aid in dying ostensibly does not really have potential for harming others, at least on the surface. I know that many have provided testimony today that indicates that this choice can have potential to cause harm. I've heard pretty compelling arguments made on both sides of that. And actually, my view on this issue has kind of evolved over the course of the hearing, which is interesting because that's the whole point of this, I guess, this process. But what I seem to be hearing from many members is that sounds like when there's doubt, though, you want to err on the side of freedom of choice. And I definitely respect that viewpoint. And I would hope that the same consideration would be given with regard to the proposed repeal of the religious exemption from vaccination with a 60-year history with no track record of causing harm. And the expert witnesses who testified in favor even said there's no emergency. So the aid of dying, I know most proponents as speculative or slippery slope fallacies. Well, all the concerns on the religious exemption right now are kind of the same way: hypothetical, no proven harm, speculative. So I just like to see us err on the side of freedom if that's what we're kind of looking to do with other issues. A lot of the verbiage I've heard today could be used, in support of this and in opposition to those other bills. So in closing, any issues that are highly controversial, I like to see that under better circumstances where everyone's voice can be heard in the conventional way, in less impersonal means, especially issues that had 17 times the amount of people sign up to testify as this one. So thank you for your time.
Thank you, Mr. Turcos. Representative Carpino.
Thank you, Madam Chair. Thank you, James, for spending time with us and for your little one as well. I just wanted to be sure I understood where you eventually landed with your thoughts on this bill. You indicated that you're, I don't want to put words in your mouth, but I think you said that your views evolved and that you also asked us to err on the side of personal freedoms, but I was perhaps it's because it's midnight, having a difficult time reconciling those. So I just wanted to know where you stood on the bill we have before us.
Yeah, so, I mean, I'm like a person of faith, and I just I'm uncomfortable with the idea of assisted suicide in general. But hearing a lot of, I was not paying attention in past years when this was playing out. And I hadn't heard a lot of the arguments that were put forward. I hadn't heard about, I did read the bill before I came to sit here, obviously. And I think that's why I said I think the bill does do a good job addressing a lot of possible concerns. And yeah, you're right. It's hard to reconcile sometimes. Like on certain issues, you can use the same argument in different ways. And I end up closer to a point where, you know, if people are making the decision between themselves and their doctor under the right circumstances, I can be more supportive of that type of idea than maybe I thought I would be coming in. And like I said, it ties in with the type of arguments that we've seen in favor, in favor of the other bills I mentioned as well that are not the subject of this hearing.
No, thank you very much, and thank you for sharing that. And hopefully you have a little bit more of a window into the wrestling we do with difficult issues and why many of us sit to the end of the public hearing so that we have the opportunity to intentionally put ourselves in these difficult situations so that we can hear from all sides on an issue and perhaps consider things we wouldn't have otherwise. And I appreciate you recognizing that these are often difficult issues and that there is no easy answer for many of the bills that are before us, particularly this committee. So thank you, and thank you, Madam Chairwoman.
Thank you, Representative. And thank you very much, Mr. Turcos, for being with us so late tonight. And I hope that you sleep as soundly as your beautiful child.
Thank you.
So good night. Good night. And that, I think, brings us to the end. Am I correct? Madam Administrator, hello? I think we're at the end. That's the end of the list.
That's the
Thank
end.
you. Thank you so much. Thank you, everyone. Have a good night's sleep. In the wonderful words of Representative Kennedy, drive safely. And thank you. You just amaze me every single time we do this. And I know it was a long, difficult day, and I just appreciate you all so much. So please sleep well tonight and have a good weekend.
See you all on Wednesday when we do our next hearing.
Oh, yes. Our next hearing is Wednesday.